Good evening, our rheumatologists in United Arab Emirates, and good afternoon to our eminent speakers from the UK, and could be someone seeing us, we could say good morning as well. I'm happy to announce this is the third edition of Experts from BSR, but on this occasion, we are very happy to have what we call a new enthusiastic generation of experts. Three of our friends, Dr. Pooja Mehta and Dr. Hasha Ginawadina, as well as Dr. Sarah Maki. This program is hosted by Emirate Rheumatology Academy, guided by Dr. Walid Shahi, as well as organized by Infomed. So all thanks to them and thanks to our audience. I will start with Dr. Pooja Mehta. So we know her from before. She gave us a very rich lectures on the post-COVID lung disease. However, her interest is in lung disease in general, and we have agreed this time she's from the University College London, and she has studied interstitial lung disease post-COVID, but then she has all the interest in research in the lung disease, in rheumatic disease, and also in immune therapeutics. She had a wide range experience with drug development and in the industry academy interface. Having designed a clinical trial rheumatoid arthritis during a pharmaceutical industry fellowship and a background academic hematology. She is a member of the COVID-19 EULAR Task Force and is currently the clinical chair of the Early Career Research Network Committee and member of the Athena committee at the UCL. She supervises and teaches MSc and medical students at UCL and Imperial College. So the stage is yours, Dr. Mehta, and thanks again for accepting to talk to us on this occasion in a new area of disease in rheumatoid arthritis. Thank you very much.
Thank you so much. And I'd like to start by first thanking you and the organisers for the invite. I also have to apologise that I'm just recovering from COVID, so my voice is a little bit suffering. So I'm sorry if I cough in advance. So as I mentioned earlier, or as Athea mentioned earlier, I'm studying post-COVID interstitial lung disease, but today we're going to talk about rheumatoid arthritis-associated ILD. Now, RA, rheumatoid arthritis, can affect all compartments of the lung, but we're going to focus on ILD today. We'll start with epidemiology and significance, risk factors and pathomechanisms, and then move on to four main clinical challenges that I'm sure many of you have encountered in your clinical practice. If there's ILD, is it disease or drug related? And how do we treat it? What about immunomodulation in the era of antifibrotics? Who should treat it? Is it respiratory or radiology or rheumatology? Do the subtypes of RA-ILD matter? Which immunomodulatory agents or antifibrotic agents should we elect for? Should we screen for RA-ILD? And interestingly, is RA-ILD actually idiopathic pulmonary fibrosis? And then we'll end with future directions, research, and the role of rheumatologists. And I just want to preface the talk with the fact that current clinical practice is largely evidence poor, and I look forward to hearing your thoughts in the discussion. So I'm a rheumatologist currently undertaking research in post-COVID interstitial lung disease at UCL Respiratory, and I'm very passionate about cross-specialty working. And we recently outlined the role of rheumatologists in the management of ILD. There are lots of interstitial lung diseases, and those with a rheumatological flavor I've highlighted in blue, and we term these autoimmune ILDs. And today we're going to focus on RA-ILD, but I just want to quickly mention IPATH, which is an interesting interstitial pneumonia with autoimmune features, a research tool where there are incomplete features of autoimmune ILD, which is a fascinating area of research. But let's talk about RA-ILD. RA-ILD prevalence and incidence varies according to thresholds for investigation, diagnostic methodology, denominators, and the definitions of controls, which may be healthy volunteers or RA patients without ILD. So the true prevalence is unknown, but a very large case control study with a follow-up period of almost 20 years showed that the lifetime incidence of ILD and RA was 7.7%. And in patients with RA that did not develop ILD, it was less than 1%. We think, on balance, that clinically apparent ILD, where patients have symptoms, occurs in around 10% of patients with RA. Most have arthritis first, around 85%. 10% have respiratory symptoms first and then develop RA later, the sort of arthritis symptoms. And very few, 5%, have the arthritis and lung disease at the same time. Subclinical ILD is fascinating, and we'll talk about this shortly, but it occurs probably in around 30% of patients. And this is where a patient with RA has no respiratory symptoms, but may have interstitial changes on a CT chest. In the literature, estimates vary up to 60%, but it all depends on when these patients are selected for scanning. The mortality of RA-ILD is very similar to idiopathic pulmonary fibrosis. Both of these conditions have very poor prognosis, and most studies report about a 3-year median survival. In this graph, you can see 3 years. The improvement in care for RA actually is improving the mortality for RA-ILD, and therefore the median survival is probably about 5 years in practice right now, and ranges all the way up to 8 years. ILD accounts for 10 to 20% of deaths in patients with RA, and a very large population health record study showed that whilst mortality attributed to RA is falling overall, deaths from RA-ILD are actually increasing, which is very worrying. We need to take this seriously. ILD is defined as the presence of radiological interstitial lung abnormalities on CT in the absence of respiratory symptoms. And this is very common, as we've just talked about. It may progress in some patients. So in this study of 64 patients, 1/3 had subclinical ILD, which progressed in half of cases at 2 years. And the risk factors for progression were age, male gender, RA disease activity, and smoking status. And although radiological progression in subclinical RA-ILD has been demonstrated, we've got to bear in mind that these are small numbers in the studies. The clinical significance is currently unclear, and what we really need is longitudinal studies in DMARD-naive patients. There are non-modifiable as well as modifiable risk factors for the development of RA-ILD. The non-modifiable are age, so advanced age greater than 60, male gender, genetic variation, of which there are many, which overlap with idiopathic pulmonary fibrosis, a fibrotic ILD, as well as other RA-specific issues like the presence of antibodies, a long diagnosis in terms of disease duration, as well as a diagnosis that occurs after the age of 50, and disability. Modifiable risk factors are always very interesting because we can try and intervene to try and prevent the onset or try and reduce the severity of ILD. Smoking is the most strong environmental risk factor for the development of RA-ILD, suggesting that the lung is the strongest candidate site for citrinylation, and I'll come back to this shortly. RA disease activity, as well as severity, and higher CRPs and ESRs are also very important, and therefore RA disease control, tight control, may actually prevent the development of ILD and its severity. A systematic literature review classified predictors of mortality in RA-ILD into patient-related, ILD-related, and RA-related. And I've put the most significant, the statistically significant ones in bold and in red. So age, male gender, a lower transfer factor on the lung function, the extent of fibrosis, and interestingly, a UIP pattern, which is a usual interstitial pneumonia pattern that I'll come back to later. So let's talk about pathomechanisms. There's been much discussion about the direction of causality. So does arthritis start in the lungs, or is the lung pathology a consequence of systemic RA? So what came first, the chicken or the egg, which is a very British saying? Is it the lungs or the joints that started first? Well, the most popular theory is that RA starts at sites of mucosal insult and barrier breakdown. So in a genetically susceptible individual, an acute infection or tissue insult at mucosal surfaces, such as the airways or the gums, which is periodontitis, results in exposure of neoantigens and citrinylation, which is post-translational modification of arginine. Then we have loss of tolerance, the generation of ACPAs or anti-CCP antibodies. And following this event, people can be asymptomatic for many years. And some CCP positive individuals can develop either airway disease or ILD with no clinical evidence of arthritis, which we call lung-limited ACPA positive arthritis, lung-limited ACPA positive ILD, no arthritis, arthritis with lung disease, or arthritis without lung disease. And interestingly, a proportion of patients with lung-limited RA progress to also develop arthritis as well. This is the same schematic at the cellular level, and essentially immune cells produce nets, neutrophil extracellular traps, which are neutrophils eviscerating their contents in order to trap pathogens, pro-inflammatory cytokines and chemokines, which all promote inflammation, airway remodeling, and fibrosis, as well as inducible bronchus-associated lymphoid tissue, which is a particular type of lymphoid tissue in the lungs. And all of these steps could be considered therapeutic targets to stop the initiation or propagation of the processes involved in RA-ILD. For example, rituximab, which we know is a monoclonal antibody directed against CD20 on B cells. So to talk about a patient that I met quite a few years ago now, in about 2014 time. This is Mr. M.A., who's a 68-year-old Asian male who was admitted from clinic with a 6-month history of shortness of breath and dry cough. He had a background of RA, disease duration 7 years, dual antibody positivity, and was still smoking. He was on methotrexate and adalimumab, and previously had been on leflunomide and hydroxychloroquine. And we admitted him because he was really very short of breath, and we performed a bronchoscopy. Now, how did we approach him? So if a patient with existing rheumatological diagnoses like RA develops respiratory symptoms like Mr. M.A., who had shortness of breath and cough, a chest x-ray, blood test, and lung function test may be helpful. It's always important to take a good history, smoking and exposures like budgies, which can give rise to hypersensitivity pneumonitis, so pets, feather pillows and duvets, very important, and a drug history. Nitrofurantoin may be used for long-term urinary tract infections and is well known to be a fibrogenic drug that can cause interstitial lung disease. Blood tests also very important, as well as the beta-D-glucan for potential PCP or PJP and aspergillus, for example. An HRCT chest, however, is the gold standard to diagnose ILD. And if there are parenchymal abnormalities, then a bronchoalveolar lavage to exclude infection. Obviously, to treat the infection, if it's positive, we mustn't forget PCP or PJP in our immunocompromised patients. If the bowel is negative for infection, but there's been a recently new drug introduced, then drug-induced pneumonitis is the likely cause, and we should discontinue the culprit drug. If there's no infection or new drugs, then RA-ILD is probably the likely diagnosis, but it's unclear what to do next. And before I move on, I just want to mention 2 things. The cell count on the lavage can be helpful. Infection is normally very neutrophilic on the bowel, the bronchoalveolar lavage sample, and a drug-induced pneumonitis, usually, not always, but usually shows a lymphocytic picture, and occasionally you can get eosinophils with a drug cause. A lung biopsy, which is my second point, is very rarely required, and we rarely do this these days unless there's diagnostic ambiguity, and a lung biopsy can be helpful if you suspect vasculitis. So in our patient, he had a HRCT chest, which showed fibrosis of a usual interstitial pneumonia pattern. I'll show you that later. His lung function test moderate. We withheld the methotrexate and the adalimumab pending the bronchoalveolar lavage. Once it excluded infection, we had our diagnosis of RA-ILD of a UIP pattern. He represents a very common clinical quandary. Mr. MA started at the green dot with a chest x-ray pre-methotrexate. He had no respiratory symptoms. And here on the y-axis, we have subclinical ILD, this red threshold, and then clinical ILD when people develop respiratory symptoms, and time on the x-axis. So he started at the green dot with a chest x-ray pre-methotrexate. He then progressed, and when he developed respiratory symptoms, he triggered a CT chest and lung function, but there were no baseline comparators. And historically, there's been a very strongly held view to consider methotrexate culpable due to the antecedent temporal treatment period. But without longitudinal studies in pre-DMARD patients, DMARD naive patients, we don't actually know what the natural history is and what the expected event rate is. And this case highlights several questions that we'll discuss in turn. So firstly, do DMARDs cause or exacerbate RA-ILD? And this is not easy, but we'll do our best. Now, steroids, we all know, are used as induction to treat acute lung inflammation, but we really mustn't forget the increased risk of infection greater than 10 milligrams of prednisolone, irrespective of the combination DMARD. Also remember that weight gain when patients are on long-term steroids can cause shortness of breath because of disordered breathing. And I'll talk about this later, but respiratory physicians have a reluctance to use steroids in patients that may have respiratory or CT scans that resemble idiopathic pulmonary fibrosis. So RA-UIP resembles idiopathic pulmonary fibrosis because of a trial that showed that steroids were harmful in idiopathic pulmonary fibrosis. And we'll talk about that later. More on methotrexate shortly, but I just want to mention that it is first line to treat sarcoid ILD. Both methotrexate and leflunomide can rarely cause a pneumonitis and accelerated rheumatoid nodulosis, even in the lungs. Hydroxychloroquine and sulfasalazine do not help nor harm the lung disease. And MMF, azathioprine, and cyclosporin may treat the ILD, but it doesn't really treat the joints. Rituximab and abatacept, probably tocilizumab, and possibly tofacitinib, have efficacy for treating ILD. Pneumonitis has been reported rarely for both rituximab and tocilizumab. And remember, tocilizumab is FDA approved for scleroderma ILD. Now, some of you might remember that there were initial concerns of COPD exacerbations with abatacept, but those have now been debunked, and therefore we safely use abatacept in patients that may have coexistent COPD. The data for anti-TNFs is mixed and more difficult to interpret, and I'll expand on this shortly, but it's controversial. Well, first about methotrexate, which is our anchor drug. This has been a long-standing controversy of methotrexate-induced fibrotic ILD, which has not yet been extinguished despite sufficient evidence to assuage our concerns, demonstrated by a recent international survey of rheumatology and respiratory physicians. Now, in this survey, which was across 6 continents, there were highly variable results between the specialties, but approximately 20% of rheumatologists and pulmonologists both considered methotrexate use as a risk factor for RA-ILD, which is really not correct. But still, we've got a lot to do in terms of messaging, because about a quarter of both specialties still believe that this can cause fibrotic ILD. Methotrexate, however, can cause a pneumonitis. So the pneumonitis is not a fibrotic ILD. A pneumonitis is a drug reaction. It's a hypersensitivity. It's rare, but recognized. We need to be aware of it. In the literature, you see figures like 0.3% all the way to nearly 12%. In reality, it's probably less than 1%. And I tend to consider it as one case in a physician's lifetime. It usually occurs within the first 6 months of starting methotrexate, and most cases within 1 year. And it usually presents with dry cough and dyspnea, fever, and a mild peripheral blood eosinophilia, but it's not a reliable sign, so don't hang your hat on the eosinophilia. The bronchoalveolar lavage is usually lymphocytic. The chest x-ray usually shows diffuse opacity. So you can see in this exemplar here, 10 days after starting methotrexate, very different to the pre-methotrexate film, but 7 months after stopping methotrexate, you can see regression almost regression back to the pre-methotrexate film. So the treatment really is to stop methotrexate as well as give steroids to reduce that acute inflammation. There's just one point that I want to highlight here that's important. Pre-existing lung disease is a risk factor for developing pneumonitis. You can kind of think of it like if the lungs are already unhappy, they may be primed, and to an exogenous drug like methotrexate, they may react. Now, it's important to assess a patient's respiratory reserve before starting methotrexate to see if they could cope with the potential decompensation in the event of pneumonitis. So whilst interstitial lung disease is not an absolute contraindication to methotrexate, severe ILD would make me very nervous about starting methotrexate, not because the methotrexate could worsen the ILD, but the risk of pneumonitis in a patient with severe ILD is scary because they may not cope with this horrible pneumonitis that could push them over the edge because they have no reserve. So in terms of fibrotic ILD, there is enough evidence to show that it does not cause fibrotic ILD. A systematic literature review showed that the quality of evidence was poor for methotrexate causing fibrotic ILD, but there was high quality evidence to show that it does not cause fibrotic ILD and may actually improve outcomes. A case control study with a discovery and a validation cohort demonstrated that methotrexate exposure was not associated with an increased risk of ILD in patients with RA, and actually may have resulted in a delayed diagnosis of ILD up to 7 years, and therefore may be protective. So the bottom line is that methotrexate may very rarely cause a pneumonitis, so we should not stop it. Sorry, we should not start it if there's poor respiratory reserve, but it does not cause fibrotic ILD. And therefore, if a patient is already on methotrexate and is diagnosed with ILD, we should not stop the methotrexate if the ILD is diagnosed. So that's a very important take-home message that I think is really not getting across in clinical practice. Do not start it if there's poor respiratory reserve, because it may rarely cause pneumonitis. Do not stop it if ILD is diagnosed and a patient's already on it. And the same conclusions can be drawn for leflunomide, as a systematic literature review has given us that evidence. The jury is out, though, for anti-TNFs, and I really like the title of this paper. Anti-TNFs in interstitial lung disease and RA, are they angel or demon? We really don't know. And therefore, the safest thing to do is that if ILD develops in a patient on anti-TNF, it's best to switch to another biologic because the anti-TNF is not controlling the ILD. The ILD is progressed on the anti-TNF. And it's best to avoid anti-TNF in a patient with pre-existing ILD because there's a chance that it might exacerbate it. And we have so many other options for RA. Moving on to treatment. Who should treat it? Do radiological subtypes matter? And what about immunomodulation and antifibrotics? Well, in our framework for managing ILD, we start with an assessment, which may have multiple domains: clinical assessment, CT, serology, lung function, a BAL, and a biopsy if we need it. In this multidisciplinary team meeting, we confirm the diagnosis, classify it, mild, moderate, severe, and then discuss the benefit risk of immunomodulation. There's then a decision to treat or observe, and then we assess the response to treatment. And of course, then we monitor clinically, but also using serial lung function and or CT chest. And we mustn't forget pulmonary rehabilitation, oxygen and lung transplantation, smoking cessation advice, and vaccination, including COVID. Who decides? Now, there's lots of models of how different people work. In the UK, it is so heterogeneous. Down the road, completely different to up the road. And I'm sure it's different where you work as well. And one school of thought, which is sadly very common, is refer and defer, where the rheumatologists and respiratory physicians both feel like it's not me, it's not my territory, it's not my responsibility. And each specialty kind of bats the decision away to the other. Another model is expected or assumed expertise, where the rheumatologist feels like it's immunomodulation, so it's me, and the respiratory physician feels like it's my organ, so it's me. And each specialty is sort of taking that decision. But my personal feeling is that neither specialty are totally comfortable or confident making this decision, and they don't really want to hold on to the ball, but feel like they ought to. A better model is shared decision making, where each specialty brings what they know, brings their expertise, and this makes the most sense to me. So the rheumatologist knows immunomodulation, the respiratory physician knows lung disease, and therefore bringing that expertise together makes the decision better. How do we decide which drug to give? Well, the efficacy, what do we know? What does the data show? The onset of action is really important, and I'll talk about this shortly. Extrapulmonary manifestations, what other features do they have? Safety, we're talking about comorbidities and frailty. I don't ever like to use age because that's really should not be an absolute contraindication. It's frailty and plans for pregnancy, for example. Access, what about your guidelines, the cost? What are your access restrictions? Prescribing habits, which may be personal or peer experience. If your colleague has great experience with a Batacept, you're probably more likely to go for that. Or if you yourself have built up a cohort of tocilizumab treated patients, probably more likely to go for that. And of course, patient choice, monitoring requirements and administration considerations. This is going to be more important when JAK inhibitors accrue the evidence and also access. When it's not clear whether it's autoimmune ILD or not, we often give this diagnostic/therapeutic trial of immunomodulation, usually an ILD with steroids or cyclophosphamide or a combination. And here we're weighing up the benefit risk. The benefit really depends on the disease severity and the onset of action of the drug. And the risk is really the side effect profile with respect to the individual patient comorbidities and frailty. Now, some of our drugs have a rapid onset of action, hours to days, usually steroids, which is why we use them as induction, and cyclophosphamide days to weeks. Slower to work, rituximab or MMF or methotrexate, which is why when we're giving somebody rituximab, we would give them steroids and something else in between, because it takes a couple of months to work. And it's very important to weigh up these benefit risks. And I'm not going to read these all out because you know these already, but I just want to remind us of a couple of things. That the infection risk with prednisolone is significant. With cyclophosphamide, we really should be thinking about subfertility and considering sperm and egg harvest cryopreservation. And we should always remember the issue of hypogammaglobulinemia with rituximab, but also COVID-19 prognosis as well as vaccine responses. And all of this is very tricky. There's limited evidence base, and it's very difficult to decide what to do, particularly in the COVID era with rituximab. And our practice has changed because of the COVID issue. And I'd be interested to hear what you're doing with rituximab too. Now, in terms of do radiological subtypes matter, the jury is out. There is a school of thought that it does matter, and it should dictate what we do, and others feel like it doesn't. And what do I mean by this? Well, unlike most connective tissue diseases, a UIP, or usual interstitial pneumonia, is more common in RA, about 2/3 of patients. And NSIP, a non-specific interstitial pneumonia, is less common. This is flipped in connective tissue disease like scleroderma or the rare cases of lupus or Sjogren's that have ILD. So in RA, you're far more likely to have a UIP. And the radiological features of UIP are reticulation, where you have thickening of septal lines. This is a good example here that I'm pointing to. Traction bronchiectasis, of which this is a good example. And here it looks like the airways are dilated and pulled apart. Honeycombing, which is here, whereas you have small cystic spaces, sort of like, I don't know whether you have the chocolate's crunchy bar, where you have an outside layer of chocolate and inside it's all honeycomb. And that's exactly what honeycombing looks like on a CT. And with non-specific interstitial pneumonia, even without being a radiologist, you can see that there's a difference. And with NSIP, you have ground glass attenuation that you don't have with UIP. And ground glass really is this diffuse, hazy attenuation. So you can see it looks all a bit murky and gray, diffuse haziness. Now, most studies show a worse prognosis with UIP, with increased mortality, decline in lung function, less steroid responsiveness, and some show no difference at all. So it's not entirely clear cut. but consistently the presence of fibrosis correlates with poor survival. And our previous practice of treating UIP, like its idiopathic pulmonary fibrosis, with antifibrotics, and NSIP, a bit more inflammatory with immunomodulation, may not actually be appropriate, as demonstrated by last year's ACR abstract, where abatacept was equally effective in RA-UIP in grey, so that's these grey lines, as well as NSIP in blue, the blue lines, in stabilizing the FVC, which is the graph on the left, and the DLCO, which is the graph on the right, as well as HRCT changes. And I previously alluded to the fact that respiratory physicians have an understandable caution with immunomodulation in RA-UIP, given that the Panther trial, which was the randomized controlled trial of steroids, azathioprine, and NAC, N-acetylcysteine, in idiopathic pulmonary fibrosis, showed worse outcomes and potential harm. So whenever you have a case of RA-UIP, the respiratory physicians are quite reluctant to give steroids because of the hangover from IPF, which may or may not be appropriate, time will tell. Now, we all know that some drugs work for both the joints and the lungs, and some for only one aspect. And I think we tend to know this better as rheumatologists than respiratory physicians. But it's important to, again, when you're communicating with respiratory colleagues, to remind them of this, because it's always, well, at the beginning, it sort of used to surprise me that they were not aware that MMF and azathioprine are not the best drugs for the joints, which is interesting. This table from a recent review summarizes studies of biologics in RA-ILD, and the criteria for inclusion here were a minimum of 20 patients, well-defined objective primary outcomes, and a follow-up of at least 10 months. And of the biologic agents, both rituximab and abatacept have been shown to improve physiological parameters and mortality. And with both agents, interestingly, there was a trend for greater efficacy in NSIP, but it was not statistically significant. There's less data, so you can see less numbers for tocilizumab, but it is promising. I'm quite excited about JAK inhibitors, and there is an efficacy signal for JAK inhibitors. The incidence of ILD in the clinical development program for tofacitinib was lower than expected, and there's a suggestion of efficacy from case series as well as mice models, with a histology score for fibrosis being lower in mice treated with tofacitinib compared to the control DMSO. And respiratory safety was comparable to rituximab in RA-ILD as well as bronchiectasis. So it looks promising. So what happened to our patient? Well, he had an RA-UIP on adalimumab and methotrexate. We gave him steroids to bridge, and we wanted to continue methotrexate and switch the adalimumab to rituximab. But as methotrexate had been suggested to him as the cause of the ILD by both rheumatology and respiratory, understandably, he declined to start methotrexate. Shows the importance of communication. Rituximab monotherapy was thought to be insufficient for his joints and his lungs, and we therefore started abatacept, and he's doing well, both the joints and the lungs, at 1 year follow-up. So let's talk about the two antifibrotic agents licensed for idiopathic pulmonary fibrosis and their relevance to RA-ILD. And I want to remind us that antifibrotics do not reverse fibrosis, but they can stop or slow progression, which I always think about analogous to joint damage. Are erosions on x-rays. We don't really heal the erosions, but we can stop progression. And these before and after pics with antifibrotics may look the same or slightly worse, and it's still a success. So nintedanib is a tyrosine kinase inhibitor, and InBuild was a phase 3 randomized double-blind placebo-controlled trial in progressive fibrosing ILD. And they defined this population as an extent of fibrosis of 10% at least on an HRCT chest, and at least 10% of FVC drop per year. And interestingly, fantastically, it met the primary endpoint, which is always very exciting in a clinical trial. At 1 year, the FVC decline with nintedanib was 100 mils lower than placebo, a relative reduction of around 60%. And the efficacy was similar across all the ILDs, including autoimmune, which is this green sector of the pie chart, and the second line in the forest plot. And a huge thanks to Clive Kelly for sharing the RA-ILD component of InBuild with me, which was 13% of the total population enrolled. And as expected, most were middle-aged men that smoked with established RA. And the efficacy in RA-ILD, reassuringly, was similar to the original trial population, which is the second line in this forest plot, although the confidence interval was quite wide. And the adverse event rate was also similar, which is reassuring. Interestingly, the baseline CRP or steroids did not influence efficacy. And it's tempting to speculate that this separation in the lines between nintedanib and placebo at week 24 was possibly due to the combination of nintedanib and biologics or DMARDs, which were permitted at week 24, although that's entirely supposition, not evidence-based. So in the UK, we are now able to give nintedanib. It was our regulatory bodies approved this. It was NICE approved last November and NHS England approved in February. And we have very strict criteria to be able to use it, but actually the criteria is quite lax and therefore the bar is low, which is great. The only things I want to tell you for a non-UK audience really is that it can cause, nintedanib can cause weight loss and GI side effects. So we shouldn't really start it if somebody is already underweight or frail or has abnormal LFTs or bowel disorders, and we should consider other ways of optimizing these. And it's not going to improve respiratory symptoms. It won't improve weight loss or appetite. And sometimes respiratory symptoms have a component of anxiety, so it won't improve that. So we should consider other causes. Also, it can cause GI side effects, as well as all of our other drugs, methotrexate, MMF, azathioprine. So if you're trying to start an immunomodulatory agent and an antifibrotic like nintedanib at the same time, if they develop an adverse event, a GI adverse event, you won't know which drug has caused what. So try and start them in sequence rather than in parallel, so you can attribute adverse events to each drug. Now, we don't use pirfenidone much because we can't, but I want to mention the very important TRAIL-1 randomized placebo-controlled trial of pirfenidone, which is another antifibrotic, which we don't know the mechanism of action, which was exclusively in RA-ILD, only RA-ILD. And this was RA-ILD with greater than 10% of fibrosis, no evidence of progression, unlike INBUILD, which you needed an evidence of progression. They had a very ambitious co-primary endpoint of at least at 10% FVC improvement or death in orange during the 52-week trial period. And it was underpowered, unfortunately, only recruited 123 of the projected 270 because of the impact of COVID, but there was definitely a signal that pirfenidone preserved the FVC compared with placebo in RA-UIP, which is in blue. You can see that difference here between pirfenidone and placebo, compared with non-UIP in orange, where there was no statistically significant difference. And interestingly, if they had selected the same primary endpoint as INBUILD, they would have met the primary endpoint. So it shows that you should be careful when selecting endpoints, when designing clinical trials. And we, as the reader, should be very careful when reading about clinical trials, because the headline is that TRAIL-1 did not meet the primary endpoint, whereas INBUILD and nintedanib did, when actually, if you look at the endpoints, both of them would have met the primary endpoint and therefore deemed to be a success, but the optics are in nintedanib's favor. So it's really important interpreting clinical trials to bear that in mind. So a couple of months ago, our patient had worsening symptoms and progression on his HRCT chest, fitting our criteria for nintedanib. His joints were in remission on abatacept, and we made a decision in an MDT to start nintedanib, and we don't yet know what happened. And again, I just want to remind us of what we need to do apart from pharmacological management, but also just to point out that if there's clinical deterioration in an ILD patient, we should consider infection with a bronchoalveolar lavage, pulmonary hypertension, clots, cancer, and gastroesophageal reflux. Both immunomodulation and antifibrotics can be used together. They are well tolerated and safe. And importantly, INBUILD, the subgroup analysis, showed that there was no influence of the radiological subtype or baseline DMARDs or steroids. I've talked about this again, but just to highlight, please don't start both drugs together, not in parallel, but in sequence, because then you'll be able to identify the culprit drug, and it's safe to add both of them together. So general considerations, we've touched on already. Smoking cessation, very important. Don't forget pulmonary rehab, and always consider lung transplantation early, vaccination, and think about what our drugs are doing in the COVID era. The data is evolving. So let's move on to screening. Should we screen, yes or no? Now in scleroderma we do, but in RA we don't. And it's really unclear. This is a subject of a lot of debate and was very nicely reviewed in this recent review. The authors proposed risk stratifying screening with either a low dose CT, lung ultrasound, or an electronic stethoscope. But the regularity of screening and how often, how many times is unclear. And when patients need to be referred to an ILD expert is unclear. Now we have guidelines for screening, and it's important to bear in mind that a screening test should be an important public health consideration, does meet the criteria for screening in ILD. The natural history should be understood. We don't in RA-ILD. There needs to be an early asymptomatic stage, which there is. The test, a CT scan, is easy to interpret, reliable, sensitive, specific, but we don't have a good policy on who to test, when, how often, who to treat, and we don't know what the benefit risk profile is in terms of treating a patient early. There are also ethical considerations, cumulative radiation doses, even if it's at low dose, and the time and cost to ILD MDTs, having to discuss all these patients. So the bottom line is, should we screen for RA-ILD? Right now in clinical practice, I don't think there's sufficient evidence to endorse clinical screening, but it's definitely an important area for research. But is that going to be in high-risk patients or in all? We really don't know. And finally, I just wanted to end on, is RA-ILD actually idiopathic pulmonary fibrosis? And the reason that people are talking about this is because RA-ILD is usually a UIP pattern, and it's clinically, radiologically, and histologically almost identical to IPF. So it occurs in middle-aged men that smoke with a UIP pattern on HRCT and may respond to antifibrotics. Although immunosuppression may be helpful in RA-ILD of the NSIP and UIP pattern and harmful in IPF, there are lots of similarities, and we've got to keep this in mind, particularly with overlapping biomarkers. And I'm not going to go into this in detail, but the overlapping biomarkers suggests that there are shared molecular mechanisms in the UIP subtype. So ending on future directions and how can rheumatologists help? This is really going to be a cross-specialty effort. We need to better understand the natural history, the influence of treatments, look at mechanistic pathways which are either shared or disparate, looking at RA-ILD, comparing it to IPF, looking at other fibrotic diseases. And we need to identify high-risk patients. This is a really nice schematic that I like, where you have phenotypes, subphenotypes within that, endotypes, which are molecular endotypes, and then treatable traits. And it's these populations that we need to identify within our broader group in order to enrich interventional randomized control trials using predictive biomarkers, and we're not there yet. This is a plug to all of you that rheumatologists really do have an important role in ILD management, in diagnosis, in the management, in research, and in service and policy, creating local and national guidelines. So to summarize, ILD is an important comorbidity in RA. It's poorly understood, it's prevalent, clinically significant, with considerable impact on prognosis, survival, and therapeutic approach, and cross-specialty working is critical. Immunomodulation, really important. We have exonerated methotrexate, I hope. It does not cause fibrotic ILD, and we should use these agents in sequence in order to identify which drug is potentially causing adverse events. There's currently insufficient evidence to screen, but maybe in the future when we have better research, we'll be able to, and research is really important. We need to validate biomarkers, identify subphenotypes and molecular endotypes, and look at shared insights between other fibrotic conditions. So I'd like to say thank you to several people in respiratory, rheumatology, and radiology, and thank you for your attention.
Thank you very much, Dr. Mehta, for the very well-designed talk, as well as a lot of information. You answered a lot of questions before being asked. And difficult area, maybe year by year, you get a new piece of information to unravel this complexity. I have a few questions here. You might have covered them, but being asked, so I ought to tell you, to ask you for them. If a patient with rheumatoid arthritis, ILD, and on Actemra, would you start methotrexate?
Okay, so they are on Actemra tocilizumab monotherapy.
Yeah.
And they develop, or we diagnose them with ILD.
ILD, yes.
Yeah, so I think it's really important to have an assessment of disease activity of both the lungs and the joints. And we know from the trial that whilst tocilizumab monotherapy is effective, it is more effective in combination with methotrexate. So we have that trial data. In order to treat the joints more effectively, methotrexate combination with tocilizumab is more effective than tocilizumab on its own. And we do know that there is a protective role for methotrexate. So there is an option to add methotrexate to tocilizumab. It depends on what that disease severity is and how the patient has responded to tocilizumab, and also what the other options are. Have they already failed rituximab, for example, or abatacept, what the other options are. So I wouldn't say a hard and fast, do this or do that, but there's definitely options to add methotrexate to optimize the disease control as well for the lungs and the joints, as well as switching to another agent. And again, with rituximab, you're going to need another anchor drug. So rituximab monotherapy, we hardly ever propose. We need another drug running alongside it. Abatacept monotherapy is far more favored. So if you were going to switch, it probably would be to abatacept, but adding in methotrexate is reasonable.
Right. Yeah, another one perhaps covered in ILD, do you stop methotrexate? You did say the severity of lung disease would make you either to stop methotrexate or continue, depends on how bad is the lung disease. Am I right?
Say that again, sorry. So if somebody is diagnosed.
Yeah, if someone already on a ILD and on methotrexate, you just diagnosed them ILD, do you stop methotrexate or not?
So I wouldn't stop it at that point, because it depends why you're stopping it. If you're stopping it because you think that they are worsening on methotrexate and the methotrexate is contributing to the ILD, then that's not appropriate, because we don't believe that methotrexate contributes to the development of ILD. But the rationale could be that methotrexate is not controlling their ILD. So you want to switch it to something else, like MMF, if their joints are under control with whatever else they're on. So it really is important that sometimes the outcome is the same. We end up changing the methotrexate to something else, but it's important to dissect why we're doing it, not only when we discuss within ourselves, so within specialty to each other, and cross-specialty with respiratory colleagues, but also to the patient. So if you stop methotrexate and suggest to the patient that the methotrexate caused ILD, you will never be able to restart it, because the patient will have in their mind that you stopped it because it caused the ILD. So it's always important that whenever we're doing anything, to make sure we know why we're doing something and communicate that appropriately.
Yeah, Dr. Nada Shama again asking, have you come across with patients, rheumatoid arthritis, ILD, and develop COVID? What is their prognosis or
Yeah, so we have had a few, and any pre-existing ILD, for whatever cause, if it's idiopathic pulmonary fibrosis, if it's rheumatic associated, sarcoid, and so on, has worse outcomes with COVID because they have pre-existing lung disease. And if they are put on a ventilator, for example, they're more difficult to ventilate. They may not be eligible, but depending on the severity of the ILD, for ventilation. And COVID can cause accelerated fibrosis in a patient who has pre-existing fibrosis. So it is an important risk factor for poor prognosis as well as post-COVID fibrosis. So we were recommending our patients with RA on particular medications that put them at higher risk for any patient with ILD to shield during the pandemic. Now that is becoming harder given the pandemic feels like it's never ending. But the patients certainly should be vaccinated to reduce the severity of COVID if it develops. And in high-risk patients, we're giving Paxlovid, which is an antiviral, or other antivirals available. So yes, definitely at a higher risk.
Yeah. Another question which perhaps you covered, that do you treat rheumatoid arthritis with MMF? You between the line you mentioned yes.
Yeah, so it's important because, I mean, we all know as rheumatologists, MMF is not a great drug for the joints. So it's a balance between what is dominating. Is it the lungs or the joints? Is it both? And therefore, what options have we got right now? And we add MMF to various combinations because we do know that it's helpful for the joints. And in that case, for example, if somebody is on tocilizumab, we know that their joints might be controlled with the tocilizumab, but adding an MMF may also help the lungs as well. So it's sort of funny combinations that we try to use to cover both aspects, which we do in lots of, I think rheumatologists are quite used to doing this, but our single organ colleagues are less used to doing this, which is why we need to really help support those decision-making processes.
We get bombarded with the questions. I don't know if we have enough time to answer all. I'll go to select, and forgive me, the other people forgive me if not choosing. There are two quick questions. One, methotrexate in bronchial asthma in rheumatoid patients. Is that any concern to you, or?
Concern in terms of infection risk. So yeah, I think that's probably what the questioner is alluding to. Airways disease is actually far more common in RA than ILD, and is less studied than ILD. And even ILD in RA is understudied. So it's really important that we do look at all aspects of lung disease. And today we've only focused on ILD. Now, methotrexate, we know any DMARD may confer a risk of infection, but so does active disease. So we've got to weigh that up. And prednisolone is also a risk factor for infection. So it's not as straightforward as saying methotrexate increases infection, therefore don't give it in whatever disease. We've got to take the whole holistic view with all the different combinations in mind.
Right, and perhaps another question, do you combine MMF with methotrexate in difficult to assess patient with lung and joint disease?
That's really difficult. So at UCL in our clinic, we haven't. But we, in our rheumatology practices, there are occasionally situations where lupus patients, for example, I've seen on a low dose AZA with MMF and so on. So there are small print cases where we do things, but genuinely for ILD, I've not combined methotrexate and MMF, and the ILD clinic at UCLH hasn't yet done that.
Just a comment, when I was still in UK at that time with the beginning era of anti-TNF, we used to have more patients on methotrexate and they might have lung disease. But only when we start TNF within a month or two, they have exacerbation or very flare lung problems. And at that time, the theory, they say, anti-TNF might change the hypersensitivity of the body to the methotrexate. That's why exacerbate. Is that theory still valid, or you have any comment on that?
Yeah, it's a really good point that you raise, because I've also had these discussions. So it sort of primes the lung to respond to the methotrexate in a different way. The only drawback to that argument is that if somebody has been on methotrexate for a long time, just suddenly develop. I did say at the beginning that my voice would go at some point. Yeah. It's right at the end.
That's the last question, I assure you.
Yeah. It's very controversial and we really don't have the evidence, but it's an interesting theory. It's just there's no way to say one way or the other.
It was a pleasure to have you. Excellent talk, and there are years to come. We will have further discussion on this topic, I'm sure, till we get the answer to all these questions. Forgive me for people who ask questions that I don't manage to get it through, because Dr. Hasha Gunawadina is waiting for his talk, and thank you very much, Dr. Mehta. Dr. Hasha, he's a very clever guy who works in North Bristol, where I worked with in a close area to him, and I used to call him, or our team called him, for any difficult area. He's a consultant rheumatologist with a specialize in connective tissue disease and vasculitis. He's consultant rheumatologist and honorary senior lecturer in North Bristol Hospital. But he works in the research area. First of all, he leads the vasculitis clinical program, connective tissue clinical program in North Bristol, and he has interest in autoimmune connective tissue disease in particular myositis, but also in vasculitis. And he has some interest or link to the topic of interstitial lung disease as similar to the earlier talk we had. So his focus on novel antibody markers, and he has published enormously, and he's a leading figure now in BSR in the area of myositis. It's very kind of him to come today and to tell us more about, I suggested, clinical challenges, because we are clinicians. Yes, we benefit from research, but also we need a guidance in some clinical scenarios. Dr. Harsha, nice to meet you, and the stage is yours.
Asir, thank you. Can you hear me?
Yes, I can hear you.
I can hear you, Greg. Can you see my first slide?
Dear Informateam, can you see? Yeah, now it's appeared there.
Yeah, and can I just check it for it moves to the next slide? So much for the invitation, Asir. It's lovely to see you again. Recently caught up at the BSR. Asir mentioned we worked together in Bristol some years ago. So it's a real pleasure to join you and your colleagues this evening for you, still afternoon.
It's our pleasure, Harsha, yes.
So thank you so much. So in the next 40 minutes or so, time for questions, I'm going to talk to you about myositis. I'm going to touch upon clinical subtypes and then give you some clinical scenarios of difficult patients that we look after in Bristol, that we see regionally, to share with you some of my experience on this interesting, but at times very difficult group of patients. Here is my declarations of interest. So what I'm going to do in the next 45 minutes or so is give an introduction. I'm going to hopefully convince you over the next few minutes that we really need to approach myositis overlap in a different way and look at redefining terminology. I think it's important in the clinical context to give you an update on the immunology and really in simplistic terms talk about how we interpret these antibodies in a clinical setting, because that's a really key component of management of these patients. Touch upon the different clinical phenotypes or subtypes that we see, give you some scenarios of difficult clinical challenges, including my approach to treatment. And now you have to appreciate that we have the new guidelines, but really from a clinician's perspective, what we do in the real life in the clinic. And then at the end, just give you some take-home messages to complete my presentation. So let's talk about you in the clinic looking after myositis patients. So I hope by the end of this talk, I am going to convince you that we need to move away from old terminology. So do I ever diagnose anyone in my clinic with polymyositis anymore? No, I do not. Doesn't mean anything. You know, it just means many muscles that are inflamed, but it doesn't tell you anything about the patient in front of you. It's an outdated term. It's a bit like in my head CREST. We don't use the term CREST anymore. We use the term limited cutaneous systemic sclerosis. So try and move away from someone being diagnosed as simply having polymyositis. Yet we do have the term dermatomyositis and we still use it, but we can be much better at defining what subtype of dermatomyositis a patient has. And then we do still use the term overlap, and there are times where that's appropriate. But what I'm going to show you over the next few slides, what I'm going to hopefully convince you by the end of this talk is, let's refine our terminology and let's stratify our patients based on their clinico-serological syndromes. And you can think of it in three broad areas. So immune-mediated necrotizing myopathy syndrome, dermatomyositis subsyndrome, and then the predominant myositis lung syndrome. And it's as simple as that. But you can see already we've moved away from saying someone simply has PM or DM. Why is it important? Well, we know patients within the idiopathic inflammatory myopathy spectrum or syndrome have a real wide spectrum of disease. It was always a fascination to me when I started off as a senior reg and then as a consultant when doing my PhD in myositis, that there were very clear similarities with patients. The shared features, myositis, skin rashes, systemic and constitutional upset. But it was also fascinating to see that within that group, there were distinctive patterns of disease. So some patients had such severe myositis, CKs in their tens of thousands, significant weakness, whereas some had no myositis or what we termed amyopathic. Some are much more at risk of lung disease, some have more severe skin disease with ulceration and calcinosis. Some look like rheumatoid arthritis with, as Pooja just talked about, rheumatoid ILD. There are patients in the myositis spectrum that have ILD and inflammatory arthritis and very little muscle involvement that fit in within this spectrum. Some have GI involvement, and we know that some have a higher risk of cancer-associated disease. So the key thing is that this group, there's a key similarity in terms of myositis or upset skin rashes, but then there are groups that just divide out into distinct patterns. So how do we identify those patients and how do we stratify them into clinical phenotypes? And the important question as a clinician, does it matter? Does it have implications for diagnosis? Does it help guide our management and prognosis? And hopefully I'll persuade you by the end of this that it does make a difference. So it's very clear that clinical serological myositis associated phenotypes have been really well defined over the last few years. And we approach it like any patient in our autoimmune CTD vasculitis. We're looking for key clinical features and robust autoantibody interpretation. And I think we would all agree on this call that a key component is combining those two alongside a multidisciplinary evaluation of this complex group of patients. One of the most important things, as well as clinical assessment, is the significance of myositis and myositis-associated ILD-associated antibodies. We want to understand interpreting those results, understanding our ANA screen, understanding extended testing, and most importantly, what do they mean in clinic? How do they help us identify hallmark clinical subtypes early to then guide management and prognosis? So let's move on to autoantibody interpretation. And the reason I wanted to include this in my talk is I think it's actually a really important area. We're now submerged in all these different autoantibodies in myositis and myositis-associated CTD, but they're not foolproof, and we need to understand them well when we're requesting them. So let's start simple, and forgive me for starting simple, but it's not a bad thing to do in this situation. So what we're clear about is anti-nuclear autoantibodies and anti-cytoplasmic autoantibodies are the hallmark, particularly of myositis syndromes. We use them always in conjunction with clinical features and not in isolation. We use them to help us identify clinical phenotypes, and in my clinical practice, they act as prognostic and potentially therapeutic markers. So your first question when you're in the clinic is, how is my ANA tested for? In this particular scenario, ANA screening on ELISA is not helpful. ANA screening on rodent tissue isn't particularly helpful. We need to go back to actually the basics, and that's screening ANA on immunofluorescence. And the reason why we need to do it on immunofluorescence is it gives us a titer, and it gives us a pattern. And it's a pattern that's important in the context of then moving on to the next step, which is extended testing. Immunofluorescence in HEP2 cells gives us a better sensitivity, gives us a titer, and will give us a pattern. So think about it in clinic as a three-step process when you're requesting your immunology. You have the patient in front of you, and then you're going to do step one, your HEP2 on immunofluorescence. And your question to your lab and your question to yourself is, what is the pattern? Is the ANA negative, but you've got a cytoplasmic speckle? Is the ANA positive and it's a nucleolar staining pattern? Or is the ANA positive and there's a speckled or a homogeneous pattern? And then once you've answered that question, you could go on to request your extending testing. And what I mean by that is your extended immunoblot testing and your ENA standard panel. And the reason that three-step process is important is, although it is fantastic we have this immunoblot technology, it is fantastic that we have recognized all these different myositis antigen targets in the last few years. It's important to recognize that the immunoblots are not foolproof. They still will give you false positives. They still will give you multiple positives on that immunoblot, particularly in patients who have what I would define as or describe as sticky serum or immunoreactive serum. So let me give you a simple example. If you had a patient in front of you with dermatomyositis skin rash, no ILD, mild weakness, and their immunofluorescence pattern was nuclear, but their extended immunoblot testing was anti-SRP, that three-step process has gone wrong at some point in the methodology. Why? Because the clinical scenario does not match the antibody result. So for example, what I'm trying to say is a patient with that clinical situation does not have anti-SRP antibodies. Anti-SRP antibodies are cytoplasmic proteins, and so the pattern should be cytoplasmic and not nuclear. So you can see what has to work here is the clinical features need to match the immunofluorescence, which needs to match the blot. And you need to be aware that these blots will give you false positives and can give you multiple positives. So always ask the question, does my patient match the immunofluorescence pattern? And does that immunofluorescence pattern match the blot result in front of me? So I started off doing myositis research in 2005, 2006. And at that point, myositis historically was recognized as a seronegative disease. There were very few autoantibodies described. But in the last 10 years or so, we have derived and discovered multiple new myositis antibodies with distinct clinical phenotypes. And this graphic is taken from a paper that I wrote a couple of years ago now, or 3-4 years ago now, which shows all the different antibodies that have been described over the last few years. And I'll come on to my next slide, which gives you a more helpful summary. So let's go back a step and talk about the refining the terminology, and then let's match that to autoantibodies. So let's not diagnose patients with polymyositis anymore. My approach would be some of those patients will have true seronegative myositis, but that is a diagnosis of exclusion because there may be mimics within that group that turn out to be alternative diagnoses. For example, the limb-girdle muscular dystrophy group. Some of those patients will have clear-cut IBM, easy to identify based on clinical features, and then a group of those patients, and I think the vast majority that we used to call polymyositis actually have immune-mediated necrotizing myopathy. Some we can redefine as having antisynthetase syndrome, and then within the DM spectrum, we can actually see that some of them have antisynthetase, some have anti-PMSEL syndrome, and then some have specific DM subsets. If you look at this nice graphic at the bottom of the slide, taken from a paper that my colleague Sarah Tansley and Neil McHugh wrote some years ago from the Bath team, you can see how we've moved on in terms of autoantibody identification from 1976, from the first description of MI2 and JO1, to 2013-14 when we described anti-HMGCR. You can see that a lot of the work was done from 2005 to 2009, and that was a lot of that work we did in Bath when we identified ZO, SAE, NXP2, and TIF1. A lot of that seminal work was done in Bath when I was working with Neil McHugh and Zoe Betteridge at the time. So let's move on to clinical subtypes. So let's talk about immune-mediated necrotizing myopathy. So in the clinic, we are talking about two specific phenotypes, anti-SRP and anti-HMGCR. They actually are very similar in their presentation. Acute or subacute muscle disease, mirrored by very high CK levels, often in the thousands, often in the tens of thousands, mirrored by troponin T levels, which are also, troponin T is also released by skeletal muscle. They have very little overlap features, and on muscle biopsy, they have essentially fiber necrosis, which is why they're defined as immune-mediated necrotizing myopathy, with endomysial fibrosis and minimal inflammatory cell infiltrate. But when you do get inflammatory cells, it's within the muscle fibers, which then leads to muscle fiber atrophy and muscle fiber necrosis. SRP patients are a difficult group. They have CKs in the tens of thousands. They have quite significant proximal myopathy, often have dysphagia, and they can be difficult to treat. Whereas anti-HMGCR is an interesting group. We know that it's linked in with statin exposure. About up to 60% of patients with anti-HMGCR will have a history of statin exposure. It's often idiosyncratic. It's not necessarily related to new statin exposure. They have a similar clinical pattern, and a group can be difficult to treat. And there is a little bit of literature coming out there might be an underlying cancer association in those patients who've not had an underlying statin exposure. Anti-HMGCR is interesting, and I wanted to share with you my own personal observation. So we're seeing more and more cases. I think that's probably because we're just getting better at recognizing it. The more recent antibody group that's been described. In the last 2 years, I've seen about 25 cases. I've got about 25, maybe nearly 30 cases on in my cohort in the last year or so. The majority have had an underlying statin exposure. The median age of onset is around 55. The median CK is around 8,000. But what's interesting in my own personal cohort is they're quite a heterogeneous group. Through the literature, they're described as being a difficult group that require intensive immune suppression. But actually, in my own personal observations, that is not necessarily the case. There is a variable prognosis in these patients. So some of my patients with HMGCR have rapidly responded to steroids. Monotherapy, weaned off, got better. A minority require steroids, methotrexate, immunoglobulin, and some require rituximab. And then a smaller minority have had very resistant disease that's led to very rapid muscle atrophy. What I can't tell you is what differentiates those three groups at the moment, but we're doing some work to see if we can identify factors within this relatively small cohort to work out why there's differences between them. But it is clear there are differences between them. There is a group that has no exposure to statin at all. It tends to be younger patients, quite obviously. We see it in juvenile onset myositis as well. And it's something to bear in mind that you don't have to be exposed to a statin. And in my experience, the patients who haven't been exposed to a statin tend to have more severe disease and are more likely to lead to muscle atrophy. Let's move on to myositis syndromes in the lung. So this is actually quite straightforward. There are specific clinical features to look out for. So again, your patient in the clinic, look out for Raynaud's, nail fold changes, DM rashes, fever, mechanics hands, synovitis. They tend to be amyopathic. They may have mucocutaneous ulceration, Palmer digital ulcers, acute phase response, and a high ferritin. And what we see is essentially patients with mechanics hands, synovitis, amyopathic fit more into the antisynthetase end of the spectrum. Patients with mucocutaneous ulcers, digital ulcers, acute phase response, high ferritin, again amyopathic, fit more in the NDA end of the spectrum. The serology is pretty straightforward. Your ANA will be negative, but your cytoplasmic staining will be positive. And what you're looking for on your blot is either an antisynthetase antibody, as shown at the bottom of the graphic, or NDA5. And then there's a subgroup of patients who have ANA positive with nucleolar staining, and they will often have PMSCL antibodies. Lung patterns are interesting. Patients with antisynthetase syndrome tend to have NSIP with organized pneumonia. Some, a smaller percentage, will have UIP lung disease. Patients with PMSCL syndrome tend to more veer towards organized pneumonia and NSIP. Patients with MMDA5 depends where you are and your ethnic background. So the literature describes Korean, Japanese, Chinese patients with MDA5 who have clear, rapidly progressive ILD, AIP, diffuse alveolar damage. That's not the case in our Caucasian patients with MDA5. I've got a large cohort of MDA5 Caucasian patients that have NSIP with OP. So I think I don't think I know, it's based on your ethnicity and your environmental background. Antisynthetase syndrome, classic features: myositis, Raynaud's, arthritis, particularly inflammatory arthritis. They often get synovitis, mechanics hands, quite a significant fever, often a pyrexia of unknown origin at the start, and ILD. It's very clear that patients can flip between that spectrum. So some patients sit more on the myositis end of the spectrum, some patients sit more on the ILD end of the spectrum. Some patients look like rheumatoid with ILD, but actually have an antisynthetase syndrome with seronegative non-erosive inflammatory arthritis. So it's a fascinating, diverse group of patients. MDA5, as I've said, depends on your ethnicity, skin and mucocutaneous disease with vasculopathy, severe digital vasculopathy with ulcers, NSIP lung disease. Some will get AIP with diffuse alveolar damage. And the thing to say about PMSCL syndrome is they actually clinically look very similar to antisynthetase patients. They also get mechanics fingers, they also get Gottron's, they also get thickening of their skin and inflammatory arthritis, and their lung phenotype tends to be OP with NSIP lung disease. If we move on to the non-lung DM subsets, there's 4 clear groups. You've got your anti-MI2 patients or anti-Me2 patients. Immunology is fairly straightforward. ANA is positive, homogeneous pattern. Me2 is picked up on the block. I like patients with Me2. I like telling patients they have anti-Me2 with DM. They tend to do well. They tend to have a good prognosis. They tend to run a monophasic course. They've got much less risk of ILD, much less risk of cancer-associated DM. We have patients with anti-SAE. They tend to have a speckled pattern on their immunofluorescence. Immunoblot, they'll be SAE positive. And SAE patients are quite characteristic. They can present with amyopathy, with quite florid DM skin changes. They often then progress to myositis within months of their diagnosis. One of the main features in anti-SAE patient is dysphagia and problems with pharyngeal function and loss of swallow, and GI bleeding and vasculopathy, which I'll come on to with a case that I'm going to present, can be a major feature as well. TIF1 and NXP2 patients are fascinating. They have ANA positivity with low level titers, so often it's missed on ANA immunofluorescence because it gets reported as negative because the titer is so low. Very clear that TIF1 patients differ between adult and patients in terms of their cancer risk, but they have characteristic skin changes, which are shown in this graphic at the bottom of the slide, with quite florid DM skin, with very psoriatic looking disease, very psoriatic looking rashes, with quite hyperkeratotic fissuring, Gottron's, hyperkeratotic keratotic papules, and this thing called red on white patch. NXP2 patients tend to have a higher risk of calcinosis, higher risk of skin vasculopathy with skin ulceration, and that's both adults and kids with NXP2 DM. We're always asked about cancer in dermatomyositis, and I've put this slide up to try and help you in your head understand cancer risk and dermatomyositis. So this is how I have it in my head. Low risk are synthetase, Me2, MDA5, and SRP. Intermediate risk, SAE, HNDCR, and what we would term a seronegative immune-mediated necrotizing disease. High risk, absolute high risk in adults, TIF1, positivity, and NXP2. And the key things in the clinic are, if you have a patient who is over the age of 45 to 50, particularly if they're a man, particularly if they have a low CK, particularly if they have widespread DM rash, think about cancer, particularly if they have TIF1 or NXP2. Always think about cancer if you have a patient with DM in front of you who has difficult to treat or relapsing disease, regardless of the antibody, and you won't go wrong. And then a new clinical sign that's been described in the literature in the last few years, look at the palate in patients with DM. There's this characteristic lesion called ovoid palatal patch, as shown in the graphic in the middle of my slide. And that's felt to be a novel finding in anti-TIF1 gamma patients that are associated with cancer and the risk of cancer. The temporal association with cancer tends to be 3 years. So what I mean by that is cancer, dermatomyositis onset 3 years, or DM, TIF1, NXP2, be vigilant for cancer, year 1, year 2, year 3. So let's finish with difficult clinical challenges and patients that I've looked after in my clinic. So let's start with some difficult clinical challenges in terms of myositis and lung disease. So let's start with patient number 1. So this is a 29-year-old lady with anti-PL7 lung dominant anti-synthetase syndrome. She's amyopathic. She has mild inflammatory arthritis. She has minimal muscle weakness, and her main clinical manifestation is fibrotic lung disease, with an FVC at presentation of 60%, a TLCO of 55%. So immediately, in my head, those markers, FVC less than 70, TLCO of less than 60, are warning signs that there is a patient's at risk of aggressive disease. We also, in our combined service, do a walk test at baseline and for monitoring. We find walk tests very helpful because what we're looking for is a theoretical distance and do they desaturate on their walk? If they desaturate on their walk, particularly below 90%, we find that is an additional adverse prognostic feature, in addition to an FVC less than 70% and a TLCO of less than 60 to 55%. So what you can see here is a progressive fibrosing NSIP. And this is a lady who was treated with steroids following ovarian cryopreservation, IV cyclophosphamide, and then soon after rituximab. And despite that, there's a progressive fibrosis. Now, I always tell patients in my clinic, in my combined CTD-ILD clinic, what we're looking for in this situation is stability. You very rarely see an improvement in FVC and TLCO and their walk test. And I'm very realistic with patients. What we're looking for and what we're defining as success is a stabilization. We do not want you to get worse. It would be fantastic if we see improvements in your lung physiology, but the key aim here is for you not to get worse. She stabilized following cyclophosphamide and rituximab, and we then moved to maintenance mycophenolate. And now with the advent, and Pooja mentioned it in her talk, now with the advent of inbuild and in the UK NICE approval, we can add in nintedanib to mycophenolate to add to the aim to gain stability and stop progressive fibrosis. So that's one scenario. A second is completely different. Friday afternoon, call to intensive care. Harsha, come and see this patient in their 40s with rapidly progressive ILD. We've noticed that they've got a rash. Yeah, it's dermatomyositis. They're test positive for MDA5. And what we've got is a rapidly progressive ILD with essentially diffuse alveolar damage. You can see from the CT top, it's right in my picture, that there's this diffuse infiltrates, which we would define as diffuse alveolar damage. There's probably some organizing pneumonia in there as well. The patient's ICU dependent, ventilated. Treatment strategy in this situation is a combination of steroids, IV cyclophosphamide. I would give IVIG in this situation because of concurrent potential muscle weakness, concurrent infection, tacrolimus in combination with cyclophosphamide, and then we would have a low threshold to move to rituximab, and then maintenance mycophenolate if the patient recovered. We may consider supportive or rescue therapy with ECMO or plasma exchange because we just need to buy time for these immunosuppressives to work, time to support the patient whilst we're expecting, hopefully, a turnaround. And you can see the patient did improve. The infiltrates disappeared, and the patient actually did very well. But that is potentially a patient that could get written off, that we may be told isn't someone that we should be trying to treat. But with plasma exchange or ECMO support, we can buy ourselves time to immunosuppress and turn the patient around. This is a case, a 38-year-old lady with anti-Jo1 synthetase syndrome. 2 years after her presentation, she had a breast cancer recurrence. She was given adjuvant chemotherapy for the breast cancer recurrence, which consisted of cyclophosphamide, doxacitabine, and Herceptin. Within 7 injections of Herceptin, she had an emergency admission with fever and breathlessness and neutropenia. She was admitted to our high dependency unit and given broad spectrum antibiotics for her lung infiltrates, which you can see on the CT scan, but didn't respond, had a continued deterioration, and on intensive care was found to have raised troponin T, high CK, elevated NT-proBNP. So the question that we had to ask ourselves at that stage, was it infection? Was it a flare of the antisynthetase syndrome? And our conclusion was based on the bloods and the imaging and the subsequent cardiac MRI, which showed uptake in the cardiac muscle, that this was a flare with an OP lung disease and a concurrent myocarditis with peripheral edema and fluid overload. We weren't sure whether this was simply a flare because she was going to flare, or was it induced by her chemotherapy. And interestingly, there are reports of Herceptin inducing myocarditis. And so we felt, well, it was probably a flare contributed to by the Herceptin. And she did very well with steroids, IVIG, and then rituximab. And that turned her myocarditis and her lung flare around. Let's move on to a different scenario. So I've done lung disease and myocarditis. Let's move on to skin disease. So let's present you with a case. A 45-year-old lady, Afro-Caribbean, who presented to her local centre 15 years ago. Classic dermatomyositis, nerve fold changes, Gottfried's heliotrope rash, proximal myopathy. Moderately elevated CK, around 4,000. MRI changes consistent with DM. ANA at that point, but bear in mind this was 15 years ago, so we didn't have the autoantibodies at that stage. So the ANA was negative. She was treated as a DM with steroids, MMS, and IVIG, and she settled and went into some form of maintenance remission. But then, some years into her diagnosis, she developed quite significant calcinosis. She moved to Bristol in 2011 and has been under my care since that time point. And in the last 10 years has had severe, progressive, ulcerative skin necrosis with underlying widespread truncal and limb calcinosis. And I have over 100 patients with DM and antisynthetase syndrome and all the other forms of myositis. And she is one of the severest patients I have looked after in my 14-year-old consultant career. The calcinosis is florid from her trunk all the way down her limbs. And you can see from the images, X-rays showing florid calcinosis. And the images, which the patient has kindly allowed me to share, show skin necrosis with underlying discharging milk of calcinosis. So she's anti-NXP2 positive, and we identified that in the last few years because NXP2 was identified in the last 10 years as being an antibody. But when she presented, she was described as ANA negative because we didn't know NXP2 existed. No response to steroids, no response to MMS, no response to azathioprine, no response to methotrexate, no response to tacrolimus, no response to rituximab. She was given intravenous immunoglobulin again, and there was a limited response, but to keep the response going, she required monthly IVIG. I don't know what the situation is in the UAE, but certainly in the UK, there is a national shortage of IVIG, extremely expensive. If you were to give monthly IVIG in the UK, you're looking at about £100,000 a year. And that is not specifically funded, and it is difficult to justify. She's IV cyclodependent. We then gave her infliximab, and she did very well with infliximab for 2 years, but then lost response. And in the last 4 months, we've been giving her tofacitinib, and I'll come on to why in my next few slides. And then the final case is a patient with anti-SAE dermatomyositis with classic dermatomyositis skin rash. And what she has is significant GI vasculopathy, and that's a common feature in anti-SAE patients. She has profound weight loss, total loss of swallow, skin ulceration, peripheral edema, and florid, life-threatening bloody diarrhea. She was admitted with a brisk PR bleeding at one point. And what she had was total gut failure. And when we looked in her gut, she had gut vasculopathy. So you can see this is a colonoscopy, and that's florid gut vasculopathy. And it's synonymous in what we see in the skin. That's dilated blood vessels leading to gut failure and essentially a gut vasculitis. She required cyclophosphamide, rituximab, IVIG, and for 9 months, PEG feeding because of complete loss of swallow. We were at a loss what to do, and in the end, I gave her infliximab, and it responded beautifully. Her skin healed, her swallow came back, the PEG came out, her vasculopathy, lower GI vasculopathy settled, and we got her off steroids. And she is now in remission with 12 months of infliximab on no steroids and low dose azathioprine. So I'll finish with some treatment tips. So bear in mind, this is not specifically evidence-based. This is what I do in the clinic when I'm stuck. We have very good BSR myositis guidelines, which I was a co-author on, which are a very helpful guide to clinicians, and they give you an overview of how to treat patients. But I'm giving you this as a sort of guide of what I do when I'm stuck. So cardiac disease, induction, maintenance, refractory. For refractory cardiac disease in myositis, IVIG, rituximab. For refractory lung disease, in the context of myositis, rituximab, IVIG, cyclophosphamide, with tacrolimus. For refractory muscle disease, rituximab, IVIG, and we are starting to use abatacept for seronegative, particularly seronegative refractory muscle disease. And this is something that I think we're going to learn about more and more in the next few months and to years. There's also signal in the studies that refractory muscle disease and dermatomyositis may respond well to abatacept. And then 2 boxes for GI disease and skin disease. So for GI vasculopathy and dysphagia in the context of dermatomyositis, induction, IVIG or cyclophosphamide, maintenance, methotrexate or mycophenolate, and then for refractory GI vasculopathy in the context of DM, I use infliximab and maintenance IVIG. And then don't forget supportive measures, particularly parenteral feeding, whether that be PEG or other forms of TPN. But refractory skin disease is a very difficult group. So what I mean by that is skin necrosis, skin ulceration, severe calcinosis. There is no right answer for this group of patients. There is very little evidence base. But the mantra is we have active disease in the muscle, the dermis, and the epidermis. And what tends to work is IVIG, cyclophosphamide, maintenance, hydroxychloroquine, methotrexate, mycophenolate. But what you want to know is how do we manage refractory or relapsing disease? And it is very difficult. I have had little success with rituximab. I have had more success with IVIG and cyclophosphamide. You don't have to use high doses of cyclophosphamide. Low dose fixed regime pulses, 500 milligrams every 2 weeks for 8 to 10 pulses tends to work with intermittent maintenance IVIG. And then I think we will be using more infliximab in this group of patients. And I think we will be using in the future more tofacitinib in this group of patients. Do not forget concurrent antibiotics. I will use as a maintenance minocycline and clindamycin, and we use it for weeks. So 4 to 6 weeks courses with then 2 to 3 weeks break alongside their immunosuppression. Why tofacitinib? It's the exciting area in dermatomyositis, particularly in muscle, particularly in lung, particularly in skin. A colleague of mine, Julie Pack, Johns Hopkins has the largest experience of tofacitinib in dermatomyositis patients. Why I have started using tofacitinib in my lady with refractory skin disease and calcinosis is a email discussion with Julie and her experience of tofacitinib in this group of patients. Interestingly, I saw my patient with DM and calcinosis in clinic last Monday, and she's been on tofacitinib for 4 months. And it's the first 4 months that I've not needed to intervene with antibiotics and wound care and need to consider topping her up with cyclophosphamide. So exciting times. It may be that we have a bit of a game changer with the tofacitinib in dermatomyositis. So I'll finish with our guidelines, which I was fortunate enough to be part of. Incredible group of myositis clinicians to work with. This is published in the last couple of months. Really helpful tool for clinicians interested in looking after patients with myositis. So bear in mind what I said in my box, my little guide boxes, is not something that's in this guideline. This is an evidence-based guideline, which has to be evidence-based. What I've given you in the last 40 minutes or 20 minutes or so is an evidence-based what to do in the clinic when you are stuck. So my take-home messages are: polymyositis is an outdated diagnostic term. When you are in your clinic and when you are doing your clinic letters, what I would encourage you to do is diagnosis, antisynthetase syndrome, diagnosis, immune-mediated necrotizing myopathy, brackets, anti-SRP, anti-MI2-DM, anti-SAE-DM. That is how you should be approaching these patients, because that gives you an idea of the complication that your patient is going to have during their patient journey. It is going to give you an idea of the treatment that you are going to need to use moving forward. So try and phenotype your patient early. Always ask yourself, do your clinical features match the antibody result? Always ask yourself, does your HEP2 immunofluorescence match your immunoblock result? Don't get hung up on CK. It's not a great discriminator. What you're actually looking for is patterns of weakness and other clinical features. I haven't talked about it because there was so much to talk about in today's talk, but when you're doing neurophysiology, always ask for nerve conduction as part of your package, not just EMG, because there will be patients out there who completely fool you and have neuromyopathies rather than true myopathies. Interpretation of an MRI is another talk in itself and is a useful imaging modality. We use MRI a lot, more so than muscle biopsy now, but interpretation of MRI is actually really, really important. And we do work very closely with our muscle radiologists to match MRI pictures with the clinical patient. Less well for muscle biopsy, because we have the antibodies, because we have MRI, you don't need to biopsy everyone, but I will still biopsy patients when I have an undefined autoantibody negative myopathy. MDT collaboration, diagnose early, intervene early, and as I've shown you, there are lots of treatment options. We are learning as we go. It's an exciting time in terms of looking after myositis, overlap, lung, skin, GI patients. It's a systemic disease and a really interesting group of patients. Thank you for your attention. Thank you, Afif. Afif, I think you're on mute. Can't hear you.
Thank you very much, Dr. Harsha, for a very thorough talk. We come to the evidence-based to practice-based or experience-based. For example, I like your guidance in terms of organ involvement, but when it comes to evidence-based, it will be less thorough because the true evidence is harder to get. Other evidence-based is more limited in that sense.
Yeah, it is. So myositis is it's been a condition that's sort of fallen behind, certainly systemic sclerosis, lupus. And I don't think that's not for want of trying. I think it goes back to the fact that it's such a heterogeneous group of patients. Doing studies when you approach the patient having polymyositis or dermatomyositis didn't move us forward. Now we can refine these patients better. What we'll be looking to do is looking at studies in antisynthetase syndrome patients and DM subset patients.
My second point, for serologically negative myositis, how can muscle biopsy be helpful in terms of cellular, let me say, pattern in that sense?
Yeah, so the point about doing muscle biopsies in your truly seronegative patients is one of my most common referrals to my tertiary myositis clinic is, please see this patient with refractory polymyositis, okay? And I would say a lot of those patients that I see turn out not to have true immune-mediated myositis. What they turn out to have is adult onset limb girdle muscular dystrophy. And there are two specific types. There's the limb girdle muscular dystrophy 2B and limb girdle muscular dystrophy type 2L. And they are very good mimickers of what we would term as having myositis. When you biopsy them, they have inflammatory cell infiltrate. When you give them steroids, they get a bit better. But they progress, and that's why they get labeled as refractory, and they get thrown, immunosuppression gets thrown at them for all the right reasons, because they've been labeled as having myositis. So the point about muscle biopsy, when they come to my clinic, I often will re-biopsy them, and then you can do through one of our national centres in Newcastle, you can do immunoblotting on their muscle lysate to identify the genetics that tell us that they have a dystrophy rather than a myositis. So biopsying true seronegative patients when they just don't fit into that true myositis overlap. But the thing is about myositis overlap and the true immune-mediated patient is they'll either have an antibody or they'll have some other form of clinical feature, mechanics fingers, nail file changes, arthritis. So when it's just muscle and they're antibody negative, you always have to consider an alternative diagnosis.
Now we come to so many numerous questions. I don't know if we can cover them all. I try to select one question is clinical scenario. Interstitial lung disease with UIP pattern, anti-SRP antibodies, normal CK, no myositis in MRI. What's your take in this pattern? I mean, the question is, do you do anything or you just like...
So the question is, a patient with ILD,
UIP pattern, anti-SRP antibodies, normal CK, no myositis on MRI.
Okay, so I would say that is probably a patient with idiopathic pulmonary fibrosis, and the SRP is a complete red herring. So right. SRP patients, A, have cytoplasmic staining on their immunofluorescence, B, have CKs in their thousands, if not tens of thousands, C, very rarely get ILD. So that will be a red herring on your immunoblot.
Do you think anti-SRP could predate the typical clinical pattern, just like, for example, we have RF predate rheumatoid disease?
So yes, it can, but it goes back to the fact that SRP has a very distinct phenotype. And that is when they develop clinical features, they have severe muscle weakness, high CKs. You know, I've got about 15 patients with SRP in my clinic. None of them have ILD.
Let's move, because we have a few questions. Try quickly. What is the prevalence of ANA in all ILD/myositis pattern? or combination? ANA, you said not sometimes negative, yes?
Yeah, so the point about ANA is we're talking about antibodies against something in the nucleus, aren't we? So we have to just stop thinking about ANA and think about testing antibodies on Hep2 immunofluorescence. That's the key thing, because what we're looking for is, does my patient have an antibody that targets something in the nucleus, i.e. an ANA, or does my patient target something that's in the cytoplasm, so an anti-cytoplasmic antibody? So the problem we've got is when you tick your box, you're ticking an ANA box. But what we're actually asking for is an immunofluorescence assay to look for antibodies to either something in the nucleus or antibodies to something in the cytoplasm. Because the key thing is antisynthetase patients are ANA negative, but their antibodies target something in the cytoplasm. Patients with SRP are ANA negative, but so it's the terminology that's wrong. I've got to be in my bonnet about ENA panels. ENA panels just confused. What we're actually doing is ANA subtyping. Let's keep it simple. Yeah. What we're doing on the immunoblot, we're doing anti-cytoplasmic and anti-nuclear subtyping.
But that's not in every lab, is it? Like they do it for you, is it?
Well, so that goes back to the methodology of how the initial step is done. So how you have to ask your lab, how is my ANA done? Right. Yeah, ideally it needs to be done on immunofluorescence. Because
we have Sarah McKee waiting now, if we can just answer these very quickly. The best treatment of calcinosis in the subtype of myositis, what is the best to resolve these calcinosis? And number two, for how long we continue IgG rituximab in other patterns of myositis? Yeah, okay. So there is no right answer for calcinosis. It is the bane of a myositis specialist's life in terms of looking after DM patients and scleroderma docs. It's a really hard problem. So the bottom line is it generally represents active dermal and fascial disease, not necessarily myositis. So you would want to control that with the standard immunosuppression. And my strategy is generally cyclophosphamide, and if that fails, either rituximab or infliximab. And then if that fails, I am now going to start using tofacitinib, because I think there is some data coming out, certainly from Julie's group in the Hopkins, that's a promising treatment. Question about IVIG or rituximab. So I do not use IVIG regularly as a maintenance treatment. Personally, I don't think it's a responsible use of IVIG. I use IVIG as induction and as rescue. And then I make a concerted effort to then follow up with either rituximab or an induction course of cyclophosphamide. But I do use IVIG early for severe patients as rescue therapy. I don't use it as maintenance monthly treatment. I think we've got other options. We have a national shortage, certainly in the UK. It's expensive. So I have a particular view on IVIG that it's a brilliant treatment for dermatomyositis, but we use it when patients need rescuing. That was brilliant, Dr. Harsha. I apologize for other people who put questions. I think we have limited time, and I'm sure we will meet again and again because there is a lot to talk about. And thank you for your contribution tonight. And we'll move on to Dr. Sarah McKee. Now we move to the north of England, which is in Leeds. Although Sarah McKee is a clever girl because she graduated from Oxford in 1999, but then she moved to train in Leeds, where I know the city quite well. She finished her PhD with giant cell arteritis in 2010, and 2014 appointed as Associate Clinical Professor in Vascular Rheumatology, Honorary Consultant Rheumatologist. She is co-author of British Society for Rheumatology Guidelines on giant cell arteritis and co-leads on OMIRACT, which is Outcome Measure Rheumatology Working Group in Polymyalgia Rheumatica, and you know these two associated diseases. Just this year, she won the British Society for Rheumatology Best Practice Award, so I'm not surprised with that. for them, it's multidisciplinary team lead giant cell arthritis diagnostics. So we have a lot to hear from Sarah Maki. It's the first time I meet you, but I heard about you too quite a lot. The stage is yours.
Thank you very much for that lovely introduction. So thank you for inviting me to come and speak to you tonight on the diagnosis and management of giant cell arteritis and polymyalgia rheumatica. Let me just advance that slide. There we go. These are my disclosures. So polymyalgia rheumatica is a common disease in the United Kingdom. I actually don't know how common it is in the United Arab Emirates, and be interested to hear from you and from some of the audience later in the Q&A perhaps. So it's a systemic inflammatory musculoskeletal disease. It affects older people. There is symmetrical inflammation around ligaments, tendons, joint capsules, usually with an elevated erythrocyte sedimentation rate or C-reactive protein. PMR causes pain and stiffness around the shoulder and the hip girdles, and this pain and stiffness causes profound disability. And these things are typically reversed with steroid treatment, at least in the short term. Diagnostically, it's notorious for clinical PMR mimics. Now, in the UK, PMR is usually diagnosed by general practitioners, and most patients are managed in the community without seeing a rheumatologist. There is some regional variation. On average, there are 96 new PMR diagnoses per year per 100,000 over 40s. And this means that the average UK GP practice would have 4.2 new diagnoses of PMR per practice per year. Swede et al. In 2006 and again Partington in 2018 looked at primary care diagnosis of PMR. And this PMR is diagnosed more commonly in the south of England and particularly the southeast of England, compared to the north of England, and is least commonly diagnosed in Scotland on a per population basis. And this is curious. And it's particularly curious because we know that PMR and GCA globally are more common in Northern Europe compared to Southern Europe. So this latitude relationship is reversed for PMR and GCA within the UK. And it's also the case that populations from Northern Europe have a higher frequency of HLA-DRB104, which is, so HLA-DRB104 is one of the HLA subtypes found in the rheumatoid arthritis shared epitope, but the association is actually different in giant cell arteritis because the shared epitope is O104, O101, and O1. So 0401, 0404, and 0101, whereas it's just the 04 alleles that are associated with giant cell arteritis risk. And the incidence of giant cell arteritis increases with northern latitudes in the northern hemisphere. We don't know why this is. So I'm going to start with a fictionalized case. And it starts with when PMR first makes an appearance in this fictitious patient. So this patient is 72 years old. She's an anthropologist. She is semi-retired. UK retirement age is now 68, and many people, particularly academics, seem to want to go on working beyond that. Her past medical history is totally unremarkable, apart from hypothyroidism and pre-diabetes. She doesn't take any prescribed medications. She's an occasional smoker. She drinks a little red wine. And she first presented to her general practitioner, her GP, with an achy right shoulder in the context of having had a mild viral infection, a bit of a family stress. And the GP discovered that she had an elevated blood pressure of 162/75, prescribed some amlodipine and offered her some counselling for stress. In the following weeks and months, the ache spread to the left shoulder and also her lower back, and also around both hips, particularly the lateral aspects and the buttocks. And this became very, very painful. So it evolved from an ache into a proper pain. And there was so much stiffness that it was very difficult for this patient to get out of bed, turn over in bed, get out of chair, or put on her shoes and her socks. GP started to wonder about PMR and asked her some more questions, and she revealed she'd been having quite significant night sweats, had been losing weight, and had a low mood. And systems review revealed that she'd actually stopped her amlodipine by herself because she felt rather dizzy and had read that it was one of the side effects. There were no particular pointers to malignancy other than the weight loss. And on examination, she was slow to rise from the chair. She had a very stiff hip gait on walking into the waiting room, from the waiting room into the examination room. She couldn't really elevate her arms past 90 degrees actively. And when she was asked to climb onto the examination couch, she couldn't actually lift her leg by itself. She had to use her arms to pull that leg up to get on there. And she looked pale and she looked tired. So the GP sent some blood tests, and this showed an erythrocyte sedimentation rate of 84, CRP of 67. She had a normocytic anemia and an elevated platelet count. Some other screening tests that were sent all came back fine, and this included creatine kinase, rheumatoid factor, anti-CCP antibody, livers and kidneys. The GP also, to be thorough, because of the weight loss and the smoking history, requested a chest radiograph, which was normal, and also serum and urine electrophoresis, which were normal also. So having looked at all of these, the GP decided on a trial of steroids. And in primary care, this is often kind of the final clincher to the diagnosis. So, right, we're going to give you some steroids and see how you feel. So prescribed 20 milligrams daily. And the patient afterwards said that this had a totally magic effect. And in fact, it was so good that she stayed up till 2 in the morning redecorating the 3rd bedroom. And she was given a taper plan as per the guidelines, which meant that she was asked to reduce the prednisolone dose by 2.5 milligrams per fortnight until she reached 10 milligrams. And thereafter was asked to reduce by 1 milligram every 6 weeks, because the guidelines recommend to reduce by 1 milligram every 4 to 8 weeks. And so, of course, the GPs took the middle of that, reduced by 1 milligram every 6 weeks. So this is how we ask GPs to treat PMR in the community. You know, does the history, examination findings, the blood tests, are they all in keeping with PMR? Think about PMR mimics, think again about PMR mimics. If it really looks like PMR and not something else, then please start at 15 milligrams prednisolone rather than 20. Is the patient happy? If they're happy, then great, and start to taper the dose gradually after 2 to 4 weeks. However, if 15 milligrams doesn't seem to work, then reassess PMR mimics, could try 20 milligrams of prednisolone. We start to get very nervous when GPs go above 20 milligrams of prednisolone for what they're thinking is PMR. The anthropologist was quite surprised. She had never heard of polymyalgia rheumatica before, and she thought she'd heard about everything. She wanted to understand what was wrong with her body, and she, what was going on with this. So what we can say as rheumatologists is that there has been a fair amount of research over the last decade demonstrating that there are fairly characteristic ultrasound abnormalities in the majority of patients with PMR. The most characteristic of these is bilateral subacromial subdeltoid bursitis. So they have a lot of fluid in that bursa without necessarily having a lot of synovitis, synovial thickening, and the synovial lining of the bursa. And a meta-analysis that we did a few years ago suggested a pooled sensitivity of 89% and specificity of 66% for bilateral subacromial subdeltoid bursitis. Other people have described that you can find abnormalities of bursitis, particularly over the C7 prominence, cervical interspinous bursitis, although there's also bursitis at other cervical spinous levels and sometimes in the lumbar spine as well. Fluid around the long head of the biceps tendon is commonly seen. Sometimes we see hand extensor tendinitis or tenosynovitis shading into this RS3PE type presentation. Bursitis of the hip region is very common, so iliopsoas, ischiogluteal, trochanteric bursitis. Synovitis of the shoulder and the hip may be seen in PMR on ultrasound, but if you see this, then we always look harder for rheumatoid arthritis as well, because PMR is not primarily a synovitis disease, it's a disease of extracapsular inflammation. And this is demonstrated well on MRI studies. So we performed a whole body MRI study, which we published in 2015. And we saw particularly the pelvic MRI would give these very characteristic patterns of inflammation in PMR that were very different to what we see in rheumatoid arthritis. So this inflammation around the greater trochanter, inferior to the symphysis pubis, ischial tuberosity, and around the hip capsule, particularly anteriorly. So PET-CT has come on leaps and bounds and also demonstrates other abnormalities. So that interspinous bursitis is very nicely demonstrated on PET-CT. Peritendinitis may be seen if you include the hands and wrists in your PET-CT, as Claire Owen does in her very nice PET-CT images. And this is an example. Thank you to Claire Owen and Aurora Poon from Austin Health for providing this image, and patient consent was obtained. We also characteristically see quite a lot of PET-CT tracer uptake, also on ultrasound we see power Doppler in the fibrocartilaginous joints, so sternoclavicula and acromioclavicula, where there's a bit of fibrous cartilage within there, we tend to see increased uptake in those joints in PMR. And everyone kept asking this patient about headache. And she said she didn't really understand why. She never got headaches. She wasn't getting headaches now. Really, she was bothered about not being able to live her life and do her activities. And of course, the PET-CTs have begun to show that it's actually fairly common for patients with polymyalgia rheumatica, particularly relapsing PMR, to have imaging evidence of large vessel GCA alongside this. So they may have PMR by itself and then flip into pure GCA. They may have pure GCA and then flip into PMR later, or they may have both at once. The image here is of a patient who presented with PMR, but in fact also had large vessel GCA alongside, as you can see in panel D and E. So, and sometimes these patients may be totally asymptomatic from the cranial GCA perspective. And of course, the systemic features of large vessel GCA are very like the systemic features of polymyalgia rheumatica. And indeed, these diseases are now considered as really part of the same spectrum. So while PMR affects more the structures that are inflamed, so the tendons, the joint capsules, and that inflammation can track down the muscle fascia on PET-CT and MRI. In giant cell arteritis, it's vascular inflammation, and that inflammation seems to come in from the adventitia and then penetrate within through the media of the artery to cause intimal hyperplasia, which then causes downstream ischemia. PMR causes stiffness with aches, whereas giant cell arteritis has its own cranial symptoms, headache, jawache, and visual disturbance. The blood profile is very similar between the two. We see high platelets. We tend to worry about giant cell arteritis, and polymyalgia rheumatica symptoms generally respond to 15 or at most 20 milligrams of prednisolone, whereas giant cell arteritis, particularly the cranial symptoms, tend to require 40 to 60 milligrams of prednisolone for a full symptomatic response. Patients are often very puzzled as to why, as they were previously well, but out of the blue, they seem to have this PMR. And in this, patients often blame viral infection. Sometimes they have an upper respiratory tract infection just before their PMR, and there's some epidemiological evidence to support that. Patients also often blame stressful events. Of course, we don't know, but clearly it's an age-associated disease, and it does seem to come on very suddenly. And so whether this final trigger appears to be different for different patients, but there does seem to be something which then causes this inflammation, which then does not go away unless we give them steroids. And in this commentary article here, we propose that perhaps resident immune cells at sites of mechanical stress may be part of the reason why this inflammation suddenly gets triggered. First of all, activating innate immunity and then adaptive immunity on a background of genetic susceptibility and immune aging. And then this inflammation and the edema. So in giant cell arteritis, there's this halo, this non-compressible area around the lumen of the artery, which responds very rapidly to steroids. And so presumably there is an edematous component there. And of course, the stiffness of joints is, if you've got a lot of fluid and pressure around your joints, then edema may be part of what restricts movement. It's important to monitor people's disease over time, and particularly in polymyalgia rheumatica, to make sure they're not developing GCA. So this is tricky because we have to assess disease activity not just of one disease, but of lots of diseases. So there's these two dimensions, PMR and GCA, but then also you've got to think about this steroid toxicity. So you may have a patient who has GCA, you treat them with steroids and they get better again. Wonderful. But then that patient may then later flare with more of a PMR phenotype without any large vessel inflammation, even if you do a PET-CT. And then maybe you might leave them a little bit and then their PMR features might get a bit better, but then they may develop more GCA features, more vascular inflammation. So they can move, one patient can move between these two PMR and GCA states to the extent to which we may question whether they really should be considered as two diseases or indeed, or just as one common disease spectrum. And of course, we have the third dimension in terms of steroid toxicity, which we also have to assess as time goes on, because it has such a big impact on our treatment decisions. So we need to follow up not only their symptoms, their GCA symptoms, their PMR symptoms and steroid toxicity symptoms, but also physical signs of all three. I ask my patients to track their HAC scores month by month if they're tapering their steroids, because this can be an early indication that things are not going so well. And if things are not going so well, I would suggest blood tests. So standard inflammatory markers and full blood count as a minimum, but potentially other blood tests as well if we're wondering about PMR mimics particularly. And if indicated, MSK and vascular ultrasound can be very helpful for identifying the inflammation related to PMR and GCA. And if we get stuck, and if we're thinking about cancer in particular, PET-CT can be useful too. The OMERAT glucocorticoid core domain set was recently defined, and this really goes through aspects of steroid toxicity that in clinical trials should be assessed. So there's a cartoon of some of these things here. So one thing is neuropsychiatric disturbance, which may be high or low mood, irritability or anxiety. Insomnia and fatigue are also important to assess. Diabetes, weight gain, hypertension, infection risk, and bone fragility. So our fictionalized case, before diagnosis, these PMR features accumulated one by one, and then she was treated with prednisolone daily and responded very rapidly. And of course, this was all done in primary care, so we don't know if she had any subclinical GCA at the onset of her PMR because no GCA imaging was done. And during that first week or two, this fictional patient, she was very happy, she was redecorating her bedroom, no steroid toxicity experienced, unless you perhaps count an over-enthusiastic desire to decorate the bedroom. But this steroid toxicity sadly was to come later. So now, of course, she's very keen to get off her steroids because she's been told that PMR goes away by itself after 2 years. There is limited evidence as to how we should taper steroids in PMR and GCA, but the guidelines which are out there describe what is felt to be good practice based on the accumulation of experience. Shared decision-making with the patient is essential, not least because we have to bear in mind several factors, including steroid withdrawal symptoms. So as we reduce, every time the steroid dose is reduced, the patient may experience a transient increase of their PMR or GCA-like symptoms, but they may then settle off over a few days. So it doesn't necessarily count as a relapse of disease when that happens, but true relapse may happen. And their potential consequences of that are significant in either case. But of course, we also need to consider the side effects of the steroids that patients are experiencing. So we have to ask them about these side effects and also the risks of long-term steroids. And as, for example, bone fragility and fracture risk accumulates over the years of taking cumulative steroids. So this is something that needs to come into that shared decision-making process. And essentially, it's really we feel our way in which we taper steroids, and depending on symptoms and signs and laboratory tests, may either escalate therapy, hold steady, or taper. So this is what we teach our GPs about how to taper steroids. We would like them to do it based on the patient's symptoms. So if the patient's PMR's pain and stiffness is controlled, that is great, keep tapering the steroids. If not, then we ask them first to think about giant cell arteritis. And if giant cell arteritis may be present, they should immediately call ophthalmology if there's visual loss, otherwise rheumatology. They reduce the steroid dose in the previous week, then perhaps it might be steroid withdrawal, perhaps watch and wait for 2 weeks first. But if it's still not better after 2 weeks, then it's probably not just steroid withdrawal. And there we ask GPs to consider whether it looks like a PMR flare. Because of course, a lot of things get blamed on PMR, and older people are allowed to have other conditions as well. So if it doesn't quite look like PMR flare, then we ask them to consider other causes of pain and stiffness. If it does look like a PMR flare, then the first thing to do is to increase the prednisolone, not all the way up to 20 milligrams, but to the last dose that worked. If they're better after a week, then great, keep on their new dose for 2 to 4 weeks and then restart the taper perhaps more slowly. If they're not better after a week, then we ask them to give them an extra boost of 5 milligrams for 3 days, then reduce by 1 milligram every 3 days till they're just above the last dose, and then can recommence the gradual taper. Patients want to know when they're going to be able to stop steroids. And there is this myth around that is sort of unfortunately promulgated by some of the information that's out there that PMR tends to go away after 2 years. And while the average patient does indeed stop steroids after about 18 months, there's a lot of variation. So more than 20% of patients that we saw with confirmed PMR in this Leeds cohort were still taking steroids at 5 years. And some other data, Italian data, is similar. So 25% of patients still taking steroids after 4 years. In the meantime, we provide sort of self-help, self-management recommendations. So taking the steroids at consistent time each day, physical activity, healthy eating, sort of being kind to oneself, keeping symptom diaries, stopping smoking is very important. And in this fictionalized case is probably going to be good for her vascular health as well as her disease, prioritizing valued activities and being patient and not giving up hope. When they get down to around 5 milligrams of prednisolone, then maybe about 50% of them do have some degree of adrenal insufficiency. And this makes tapering feel hard work, but it doesn't mean that you can't taper. It just means that you have to taper extremely slowly. And ultimately, the adrenal gland almost does always recover. But some liaison with endocrinology can be useful. So in our fictionalized case, she did have a couple of attempts at tapering over 20 months. Firstly, when she got to 3 milligrams of prednisolone, her PMR symptoms returned, her CRP rose, and so the dose was increased back to 10 milligrams. On the second attempt, she got to 5 milligrams, PMR symptoms returned, and this time she was dizzy again. Dose increased back to 7 milligrams and everything resolved. Third attempt, she was really fed up by this point. She was putting on a lot of weight, struggling on the stairs, but weak rather than stiff. And so steroid myopathy was suspected. CRP was totally normal. She was absolutely determined she was going to get off steroids this time. She got down to 1 milligrams, but then over 2 weeks, new symptoms developed. And she still didn't have a headache, but she said her head felt strange. And when she brushed her hair, her scalp was sore. And when she was chewing steak, her jaw became achy. Soft foods were all right, but she couldn't finish her bagel. And finally, while she was watching TV, she had transient visual loss in her right eye, which lasted 4 minutes and alarmed her. And so she ended up in A&D. So far, we have a few symptoms, and we're in a patient with prior PMR. So having prior PMR really does raise your pre-test probability of this being GCA. So these figures here are from a meta-analysis that we published back in 2020, and it was an update on the rational clinical examination paper where we meta-analysed all the cohorts of patients investigated for giant cell arteritis and looked at the prevalence of all the various GCA symptoms in those who did and who didn't turn out to have GCA. So the likelihood ratio, if likelihood ratio is more than 1, that upgrades your clinical suspicion of having GCA in this case. The likelihood ratio is less than 1, and that downgrades your suspicion. So she didn't have headache, and the negative likelihood ratio associated with headache is 0.61, so that downgrades us a little bit. But she did have scalp tenderness, and so that upgrades us. So the odds of her having GCA are increased by 1.85 fold. But she also gave this history which is very light jaw claudication. So that increases your odds of having GCA 4.9 fold. It's one of the strongest diagnostic pointers towards GCA that there are. With active PMR symptoms, that would further increase the probability of GCA. And there are some things that we don't know yet because she hasn't yet we don't yet know about the examination findings or her blood tests, but if her temporal artery was abnormal, that would also increase the likelihood of it being GCA. And if the ESR was greater than 50, that would also somewhat increase the likelihood of it being GCA. So here we have a patient who was struggling a bit while tapering steroids, but we're not really sure whether this was steroid toxicity or PMR or GCA, but then suddenly something flips her into giant cell arteritis. In over weeks and then days, the GCA symptoms accumulate and we have crisis. So she's in A&E, blood's been immediately sent to the laboratory, and high-dose steroids are immediately started because this history of jaw claudication very concerning. She was referred on to ophthalmology because she had this episode of visual loss, but they said, oh, no retinal changes at all. We can't see any problem. Rheumatology, please take a look. And so by this time, her blood tests are back and her ESR is 20, which the trainee thinks might be normal for her age, although I'm not sure it really is, and CRP 6, which is also not quite normal. And it was commented that it was difficult to feel the temporal artery pulsation on either side. And a temporal artery ultrasound confirmed a halo sign bilaterally in the temporal arteries, possible axillary artery thickening. But the sonographer commented that this was a smoker, and sometimes we see even halo signs of atherosclerosis, and therefore a temporal artery biopsy was requested alongside. And this was reported showing panarteritis with giant cells. So this is what the BSR guidelines suggest in terms of the sequence of tests and how to use ultrasound. So in this individual, there was quite a high pre-test probability of giant cell arteritis, but the ultrasound result was a bit equivocal because the sonographer wasn't sure whether a halo sign might have been due to potential atherosclerosis, and so a biopsy was requested and came back positive. And so we continued to treat this patient as GCA. And of course, while she was having these tests, we were still continuing the high-dose steroids because of this high level of clinical suspicion. These are the histological features of giant cell arteritis. So on the left, you can see a normal temporal artery. You can see the muscle layer of the media looking very normal. And then inside that, the internal elastic lamina, which is wiggly and pink. And on the outside, a normal adventitia with some vasa vasorum, some smaller blood vessels that help to oxygenate the layers of the temporal artery. The middle image shows a panarteritis type of presentation. So here, the media is infiltrated with inflammatory infiltrate and is in places pretty much destroyed. There's fibrosis laid down. There's gross neointimal hyperplasia. So the lumen has become just a very small a slit almost. And within the adventitia, we can see multinucleated giant cells. And there's a magnified view of this here on the right. These are images from the UK GCA consortium study, which was commenced when I started my PhD in 2005 and is still ongoing, where we're collecting a large UK-wide cohort of patients with GCA. So we don't just see panarteritis, so panarteritis means inflammation of all three layers of the blood vessel wall. So this key publication from Maria Sid's group in Barcelona, it categorizes the different patterns of giant cell arteritis according to the progression of the inflammatory infiltrate in the disease. So initially, the earliest findings are this adventitial only inflammation, where the inflammation is just in the adventitial layer. There's then an adventitial invasive where it just starts to punch through the media but hasn't quite reached the intima yet. A concentric bilayer is where we see inflammation in the intima and adventitia, and the punch through has happened somewhere else that we don't see on the section. And panarteritis is where we see inflammation in all three layers of the blood vessel wall. And the panarteritis phenotype is the one which is associated with the full-blown lesion, and that's where we tend to see the grossest near-intimal hyperplasia, vascular occlusion. And these are the patients who are at risk of developing downstream ischemia because the blood just can't get through. So in this fictionalized case, this patient was given 60 milligrams of prednisolone daily, and this was during the first wave of the pandemic, refused admission for intravenous steroids. And it takes a long time to get someone to be admitted for IV steroids anyway. And so often 60 milligrams of prednisolone, or sometimes even 100 milligrams, is the most pragmatic way to treat acute GCA symptoms in everyday practice. So over the next 2 weeks, the headache resolved. She had no further visual symptoms, of which everyone was very relieved. Her jaw claudication did gradually improve. However, on the high-dose steroids, she became hypertensive, couldn't sleep, became very tremulous, became very irritable, and started having mood swings. And so methotrexate was added early, with some discussions about alcohol and the need for regular blood monitoring. So here we have a patient who, on high-dose steroids, GCA activity settled almost to nothing, still had a bit of jaw claudication. But then what happened is that we attempted to taper her steroids, and despite methotrexate, GCA symptoms started to return. So she was tapered down by 5 milligrams per week as per guideline, and the reason once she'd been in remission for a few weeks, the reason that we wanted to taper soon in this fictionalized patient is that she was getting a lot of steroid toxicity. So then the headache started to return, but she was becoming very Cushingoid and also by now diabetic. So we kept tapering, asked her to follow a strict diet. Gliclazide was started for her diabetes, but she got down to 20 milligrams, and then her jaw claudication returned. And so then the prednisolone dose was re-escalated to 40 milligrams, causing further toxicity, but did settle her GCA symptoms, and tocilizumab was added. So currently, NHS, although tocilizumab is licensed as a treatment for giant cell arteritis, because it's expensive, NHS England is currently funding just 1 year of tocilizumab, and it's restricted to relapsing or refractory giant cell arteritis. So in England, we can't start it in new onset GCA, unless it's labeled refractory, we have to wait for them to relapse. And this is an example of the sort of situation where we may use tocilizumab. These are what the BSR guidelines says about GCA relapse management, and notably it recommends that if it's just headache, then but no ischemic manifestations, then it might be just okay to put them up to the previous higher prednisolone dose, as we would for a PMR flare. If they're developing jaw or tongue claudication as an ischemic manifestation, we would become concerned that this might be more of a, what is now called by EULAR, a major GCA relapse. And so we consider re-escalating to high-dose oral prednisolone with or without a glucocorticoid-sparing agent. So methotrexate or tocilizumab would be considered in this situation. If they develop non-cranial symptoms, we would still worry. So it could be just PMR, but it could be that they're developing large vessel vasculitis. And if that's the case, we would generally recommend investigating them with vascular imaging and considering increasing the oral prednisolone in order to control those symptoms. So new visual loss or diplopia would need to be urgently evaluated by an ophthalmologist, and we would measure acute phase markers. If they're elevated, that's helpful, but commonly, as with PMR in patients taking steroids, the acute markers may remain suppressed during a relapse. So if normal acute phase markers in the context of GCA relapse wouldn't necessarily deter us from increasing the steroids. And still the only agents with phase 3 trial evidence for glucocorticoid sparing in GCA are methotrexate, tocilizumab, but there are some new therapies hard on the heels of tocilizumab. Phase 2 trials have been completed, phase 3 trials are underway, and we await developments with interest. So with the tocilizumab, finally, in this fictionalized case, managed to taper down the steroid dose. She even stopped smoking mostly, although we're not sure if she totally did. She reversed her diabetes via diet, exercise, and tapering the steroids. She shielded, so she stayed in her house through the first wave of the pandemic. She was first in line for all the vaccines for COVID, followed all the masking distancing guidance, and so far this fictionalized patient has not knowingly had COVID-19, and 18 months into her tocilizumab treatment, she had got down to 4 milligrams of prednisolone, totally asymptomatic, very happy. Steroid toxicity had mostly resolved apart from skin fragility, and in this fictional case, she is just won a prize to go on a round the world trip, including the United Arab Emirates, India, and the Philippines, and wants to know, can she go? So this, I guess, is an example of how we then try to reconcile this chronic disease requiring long-term immunosuppression with patients' desires to go on holiday while they still can, while they are feeling well. And notably, of course, with tocilizumab, she only gets 1 year of that on the NHS. So 4 months into her trip, then the danger is that tocilizumab may need to be stopped, and she might potentially flare again. She wants to know, why wasn't she started on methotrexate sooner after first relapse? What if the GP had referred to her earlier? Could that methotrexate have reduced the amount of flare she had? Maybe it would have prevented GCA entirely, or at least she might not have needed such high doses of steroids, which caused her so much toxicity. And of course, we don't know. But the way that our pathways are currently set up is that we say to GPs, please don't refer unless you're concerned that it's not PMR, or they're getting lots and lots of relapses, or they've been on steroids 2 years or more. So Sterling PMR is a clinical trial which I'm leading, which is currently in setup. We're going to recruit patients with PMR who have relapsed, and we're going to recruit them from primary care. They need to be still taking steroids. We plan to recruit from 20 UK hospital sites, 20 GP practices per hospital, so 400 practices in total, and it will be an open label trial. They will have DMARD therapy alongside their steroid, or they will just have steroid by itself. And the DMARD would be first line methotrexate, second line diflunomide. Steroid tape will be managed by GPs. DMARDs will be managed by rheumatology, and the outcomes will include cumulative steroid dose over 18 months, which is the primary outcome. And we are also going to ask patients to complete monthly questionnaires covering their PMR symptoms and steroid side effects. So there are many unresolved questions in PMR and GCA. One of the weird things is, why is this north-south attitude gradient of PMR GCA reversed in the UK? Perhaps it's socioeconomic factors. Should everybody with new PMR have imaging to rule out concomitant GCA? Currently in the UK, this doesn't happen. What's the role of resident immune cells in triggering PMR or GCA? How do we disentangle PMR, GCA, and steroid toxicity when a patient has all three? What do we do about these potential false positive temporal artery ultrasound in patients with atherosclerosis who needs to go on to have a biopsy as well? In GCA relapse, can we just start tocilizumab rather than increasing the steroids? How should we manage hypertension in active PMR or GCA, particularly if there might be vertebrobasilar involvement from large vessel GCA? When and how should we stop tocilizumab? What's the long-term outlook, and when do we tell patients to take their holidays? And I'll be very interested to hear questions.
Thank you very much, Dr. Mackey, for this excellent overview. I have a few questions already. I was about to ask one, but you already answered it in terms of Sterling PMR, because why we don't adopt the same approach in rheumatoid. We give these disease-modifying or steroid-sparing early enough. And you already going to give us the answer when the study completed. So I take my question away. Let's go to audience questions. Okay, the first one is about when you do ultrasound, you find bursitis, tendinitis. How do you know this is PMR, or how do you know this is enthesial disease of different nature? I don't know, like psoriatic arthritis or something else. Sonographic changes, that's particularly in the question.
Yeah. So we don't routinely ultrasound everybody presenting with new PMR, because again, these patients in the UK tend to be presenting in the community, and GPs won't have ready access to musculoskeletal ultrasound in the majority of cases, although that is now coming in and is helpful. The spondyloarthropathy spectrum disorders are a really, really common PMR mimic. So now that we have sort of good serological tests for rheumatoid arthritis, we have rheumatoid factor anti-CCP, actually that is less often in reality a PMR mimic at the moment, but spondyloarthropathy, psoriatic arthritis, inflammatory bowel disease related arthritis, ankylosing spondylitis, these commonly mimic PMR. And so it's really, really important when assessing patients as potential PMR mimics to ask them all the SPA questions, which you will all know. And look at nails, plantar fasciitis, Achilles tendon, all of these things, and to be alert for these features to also pop up as the steroid taper continues with PMR. So when they have that first relapse, particularly if they're getting a lot of costochondritis, a lot of these axial spar features, to think about SPA. And what we see on the MRI, if we do MRI, is that there's the enthesitis, but without the osteitis component of enthesitis. So it's very much focused around those tendons and ligaments without affecting the bone. And of course, on ultrasound, we can't see osteitis, so we can't really discriminate. In general, there's less of a florid synovitis with PMR, it's purely effusions, but there is an overlap. So I think that, again, it's clinical acumen always, and a lot of patients who make their way to rheumatology with relapsing PMR, in fact, have something more along the SPA spectrum.
Right. Thank you for this one. Second one, there are two questions. Like, one is the percentage of possible malignancy as PMR mimic. I've seen it a couple of times in paraneoplastic or this pattern, but how often do you see that? Or what's the?
It is unusual. I think it's much less of a problem now than when the current guidelines were published. So the guidelines that were published in 2010, I think there was much less, the cancer pathways are much less well established. And so now that there's ready access to imaging for suspected malignancy in patients who are losing weight without clear cause, we have vague symptoms pathways where patients get a malignancy screen very efficiently. So actually it's less common for malignancy to present in a PMR-like way, but of course we do tell GPs to think about it, because there will be the odd patient who will have a malignancy, but it is uncommon. It is uncommon. It's more likely to be other rheumatic inflammatory diseases, perhaps an infection, but that would normally get better by itself quite soon.
Do you see PMR or GCA in people of African origin?
Certainly there are patients who have had positive temporal artery biopsies of GCA who are Black. So yes, and in the United States, African Americans get GCA just like white Americans. It seems to be, we see it a little bit less compared to in white patients, but it does exist. And it's very important not to dismiss the possibility of PMR or GCA just because someone's not white, because clearly that's just skin color, and we don't want to miss, particularly GCA with its ischemic consequences. We don't want to have a delayed diagnosis in people who don't fit that stereotype.
Right. Okay. Next question. Refractory PMR with no GCA, no mimics, cannot drop below 15 milligram. What do you do?
So those patients are really tricky. We would tend to go in first with DMARDs, and the best evidence is for methotrexate. So I would start with methotrexate. If that doesn't work or isn't tolerated, then I generally go to leflunomide next, and would cycle through all the sort of conventional synthetic DMARDs. I worry about mycophenolate. It's very immunosuppressive for this patient group, and I worry about so I tend to steer away from mycophenolate. There's no biologic therapy licensed. There have been some very encouraging phase 2 trials of various agents in PMR, including surprisingly rituximab, in quite a small trial. So perhaps in the future, we'll be looking at biological therapies for a subset of patients. And of course, throughout all of this, we need to convince ourselves that it really is genuine active PMR and not perhaps steroid toxicity masquerading as PMR. But if it really is genuine PMR and these patients do exist, then we really, I think, we can't just manage them with steroids alone if they're on 15 milligrams of prednisolone. I think that's too much for this age group, and really try and find whatever in each individual. And anecdotally, different patients will respond to different DMARDs, just as in RA, and we have to keep switching until we find something that suits them.
I think you briefly mentioned about the next question. Let's say, do you use rituximab in GCA? If you mentioned there's a small work on.
So there is evidence that there's B cells, particularly around the aorta in large vessel GCA. There's this trial of rituximab and PMR, which is bridge PMR, very small trial, but that was a phase 2, and I think they're now going for a phase 3. So very preliminary evidence. And there's a couple of case reports of rituximab for GCA with mixed results. I think in the context of the current pandemic, and the concerns about vaccine responses in patients who are already immunosuppressed, again, a bit like with mycophenolate, I would be a bit worried about using rituximab, even if I were allowed, which wouldn't be funded currently. I just think the potential for impaired vaccine responses and problems with COVID outcomes, that's just too much of a concern still. I don't think the COVID era is not over.
Right. Okay. The role of anticoagulation, aspirin, warfarin. Aspirin, I think that it was fashionable at some point, aspirin. Yes. But then this is kind of fading away a bit.
Yeah. So I think that in patients who present with something that could be a transient ischemic attack atherosclerotic, it makes sense to start aspirin alongside. If you're not sure yet whether it's GCA or a sort of an atherosclerotic TIA, it kind of makes sense to start aspirin just to cover yourself alongside steroids. There was a vogue for giving everybody aspirin, but then the concerns are, of course, that the toxicity of this alongside everything else is not trivial, and there isn't really any convincing evidence that aspirin is beneficial. So I think the guidelines do not make a recommendation to start aspirin now. And having said that, with severe giant cell arteritis, when they're in that early phase, particularly if they've got TIA or threatened stroke, it would make sense to think about some kind of antiplatelet agent just in that acute phase until you've controlled the inflammation sufficiently. But long-term aspirin, I'm not sure of the benefit of that at the moment. I think studies need to be done.
Yeah, I know we are asking too many questions. We are approaching the time. Is a question outside the box from my friend Dr. Pai is what type of or steroid sparing or immunosuppressant you use in Takayasu disease, which is outside this box.
Yeah. So so Takayasu is interesting because it is sort of shades into giant cell arteritis, but it is different, and often that will respond quite nicely to TNF inhibitors. So TNF inhibitor will often work in Takayasu and is worth trying, and tocilizumab as well, clearly. So those would be my first two picks for Takayasu. And of course, we monitor Takayasu differently with regular large vessel imaging is really key to determining treatment response and prognosis. And then potentially in future, we might be again looking at different biologics, and again, doing trials in Takayasu is even more challenging than doing trials in giant cell arteritis. So we may have to also borrow some agents from giant cell arteritis in future. And the new classification criteria for Takayasu GCA are interesting because they give you this intermediate category where they're sort of in their 50s, and you could call them Takayasu or you could call them giant cell arteritis, and then so you might go either way with the treatments.
Right, about your question, what is the prevalence in Middle East? I work in UAE and we have a mixed pattern. Some hospitals see only nationals, which is around 20% of the population. The other hospitals see only the expats, and some are mixed.
Yeah.
If you see the expats, they are usually younger age group, working class. Rarely you might see a PMR or GCA with them. I've seen a couple rather youngish in the 40s.
Wow.
Yeah, but not many as you would see in UK, for example. In the nationals, in the government hospitals, the percentage is, I cannot give you rough estimate, but they are there. Similar to UK or maybe less, but I don't have figures to tell you. But in the nationals age group, yes, you see them. So it's there, and but people working in the, let me say, expat hospitals,
they won't see it so
the disease, but as it is.
Yeah.
Okay, I would like to thank you, Dr. Maki. It was very nice and very comprehensive review. A lot of questions. As I also apologize for some other questions, but we are limited with time, and it's becoming late here in UAE. And thank you very much. We hope to see you again in another occasion. And from the Emirates Rheumatology Academy, I would like to thank all the audience. I hope all the three excellent speakers gave you really the benefit and updates of the science you need in every day. And hope we meet again next year on the 4th edition of Experts from BSR. Good evening and thank you all. Bye-bye.